I think before I go through the welcomes and apologies, I just thought I'd just do a bit of an intro, if I may. There's something for me about recognising at a point in time how we're doing. And we've had some challenging times. We've still got some challenging times. But when I look at the board papers this time around and having some of the conversations as I had with most of you before we get here anyway, I have to say, when I look across the myriad of things that have gone on and we're doing, it feels like we're making strong progress. So we've still got major challenges, but I could encourage you as we go through today to equally consider the challenges we've got, but equally focus on the things that you would like to pick out that you think actually we should be celebrating, because having, as part of the board pack, got here an operating plan and budgets and other agenda items, there are a number of things that leap out, and it would be very easy just to leave them buried in the pack today. So if I can encourage you to be as equally supportive and in celebrating mode as in challenging mode today, that would be great, because I wanted to thank the executive teams for what they've done and committee chairs. I think it was a really strong set of papers. That's normally the case, but these are particularly strong in doing that. So anyway, right, on to the main session. So welcome everyone, and a particular warm welcome to Tracy. Tracy, welcome. You are our Chief of Staff. Please say a few words.
Yeah, thank you. It's really good to be here. I've worked in Cornwall for many years. Most recently worked at UHP, University Hospitals Plymouth, as the Chief of Staff there. And I'm now returning to Cornwall. I was involved in the designation of the ICS before I left. So, and I think I've worked for all of the NHS organisations in Cornwall, including primary care. So, yeah, really good to be back in a system role.
Welcome back.
Thank you.
Okay, so I've received some apologies today. I'll just go through them. I've got Andy Sant, Margaret Schwartz, Russell Ashman, Rachel Pearce, Steve Moore, Sanj, and Nick may or may not be. Nick, did you catch the plane in time, or are you catching it later?
So, Chair, the plane is due to hopefully take me to Cornwall over lunch. So I should be with you by the end of the day, but I'll be online until that point. Thanks.
Now, you're down to make some comments for me just before 12:30.
Yes.
Will you be around then?
That's 100%. That's fine. I'll be online then, Chair.
Lovely. Thank you very much. I'll just double check. And Debbie, you need to leave early.
I do.
That's not a problem. Thank you very much. And is it Professor Shankar who will be joining us later?
Yes, Professor Shankar, coming in person.
For the deep dive. Here in person.
Lovely. For the deep dive.
His reputation has preceded him, which is all good stuff.
Yeah, I think we're in for a really exciting presentation. I've heard him speak several times, so
we're looking
it'll
forward
be an opportunity for the board to see clinical leadership in action.
Yeah.
Very good. Okay, thank you. So let's move on. Declarations of interest. Any declarations? Yeah.
Yes, I have made my declaration. It's not quite in the paper yet, but I'm currently a non-executive director for Artswell. I'm in the process of stepping down because I'm going to be involved in the creative partnership, so to avoid any conflict of interest.
Oh, that's very good. Thank you very much. Any others? No? Okay, thank you. So let's move to the minute of the 11th of April. Can I take them as accurate? Are you happy for me to sign them off? Yep, lovely. Thank you very much. We'll do that. So then we move on to the health and care vignettes. So, Lucy, I'm going to ask you this particular time, just give us a couple of highlights from your perspective as to this week's vignette.
Thank you, John, and I'm really pleased that this month's themes are around mental health, and thank you to Tan for doing that, and also for Debbie's communications team for supporting the production of the films. I think it's really important to look at both the support throughout mental health and the life stages, which really complements our integrated care strategy. And in particular, I was really impressed with the mentor and support for young people as they transition from primary to secondary school. And also the story from Tom, which we've complemented with Man Down's promotional video for the year as they support men through their mental health as well. Thank you.
Good. So I'll open it up to the floor. Tom.
Yeah, I'd just like to say I thought that those vignettes were really, really powerful. I think I was really struck by Hayley's story. But I was also struck by the role of non-medical intervention and how we can move there for people taking power and being supported to make the changes across their lives. And I think what it does need to remind us all as we come towards Mental Health Week is a need for parity investment in mental health as well as physical health, and in backing people to make the most of their health and well-being for the future.
Can I just ask, from your perspective, clearly this will be relevant, particularly to our deep dive later on. What are your thoughts on some of the things here?
So, well, the first thing is I really welcome the opportunity, and it was a great idea from Tan that we mark Mental Health Week, which is next week, with these themed vignettes. As much as it was a pleasure for our teams to work together on it, the challenge they had, Chair, was actually filleting the number down to just 5 to meet with the agenda, because actually once we engaged people in the what should we take to board to showcase, there were many, many, many more ideas that were bubbling up, and I think theming the vignettes was really helpful, and I wonder whether it's something that we could consider for other areas as well as we mature. I think what we tried to do in those short vignettes was also talk about how we empower people to actually self-care, and how we also support people to become peer supports, mentors, as well as then when you really need it. So, for example, Hayley's story, at that point, she really did need some specialist intervention to help her onto the road for recovery. There is not one single intervention with mental health. There is not one single condition or symptom of mental health. So I think it was it is a very proud moment for the ICB. I would also just like to highlight that as next week is Mental Health Awareness Week, we've got a range of activities planned across the county, some for staff, so that we can really encourage our staff to talk about their health and well-being, and also our service users have worked together. So we've got a number of resource centres that are delivered in partnership between the council, CFT and the VCSE, and there are 13 VCSE organisations involved across the county next week in just 3 events. So there are many, many more events. So I think if we can just continue to promote Mental Health Awareness Week and continue to promote the number of different agencies that are really working together so constructively in this space, and continue to promote the real importance of co-design with people who use services.
Given that level of promotion that you're asking for, Lucy, are you feeling confident that we're on top of that as a group?
Yes, we've got a really robust plan. There's almost every day next week there's media activity as complementing all the activity that Debbie mentioned.
Okay, so we're going to go Rachel, Martin, and then Ali. Rachel.
Thank you. Yeah, I support what people said about the raising awareness and focus on mental health and across the life course. All of those examples really showed how important the importance of it, and not just services, but also the well-being element of mental health, and that it is everybody's business to do that. It's not the responsibility for health treatment services in CFT. It should be considered through all of our work, and I think that there are good examples of that, although I think we know that it's still a challenge, isn't it, in Cornwall, that we do have high suicide rates, and there's a lot more to do in this area. So really welcome that, and particularly, as Tan said, around the opportunities for peer support, and those examples that the young people gave, I thought were really moving, and particularly seeing young people saying how important it was that they were helping other people. That really touched me, to hear all those young people expressing that. So good hopes for the future.
Excellent, thank you. Martin.
Thanks, John. Yeah, I really enjoyed the vignettes this month, as usual. I suppose a couple of thoughts from me were that I really enjoyed actually the way that we, first of all, enjoyed the peer support. Thanks for raising that again, Debbie, because I think that's so nice to have people who've lived some of the experience to help other people, and it's probably super valuable for those receiving the secondary support to know that other people have been through it. I was struck by the sort of slight synergy in terms of, you know, we've got the one with people with mental illness being helped into work. We've got something later about with learning disabilities being more engaged in research. And I know we've got our new committee to get more voices unheard into the board. I think all that aspect about bringing people, those hidden voices, into everything in general, as well as the board here, is super important. So I'm glad that we are doing something in that respect, as well as getting the papers on it today. I suppose my one, slight concern was the one in the man down. I think it was Tom. Seemed to have some difficulty, reaching the service that he needed. He went through his GP initially, was sort of turned down by the receptionist, etc. And I just wonder. I was hoping that wasn't the only way into these services. Maybe it is. If it is or if it isn't, how do we sort of better publicise, how people can access the services when they need them, or do you think we've done enough?
One of the reasons why you and I have had a conversation on talking therapies is that I was taken by some of the comments made to me on that theme that you've raised by some people who are trying to source services, basically saying to me, look, when I'm in it, it's great, but actually I'm not quite sure how to engage and where to engage. And of course, their first port of call was to actually go to the website and look. And unless you write in CFT or whatever, it wasn't an obvious Google search to come up, or their next door neighbours or whatever didn't know. So everybody knows about the acute or whatever else, but maybe it's not so profile. So how do we take that theme forward?
I think it's the Kelvin and I double act, but could I just take the opportunity to say anyone who's concerned about their own mental health well-being, or any family member, relative or friend, should use the 24/7 mental. That's, if you need one number, that's the number, and I'm sure we could put that through on the live stream.
Kevin, one of the things that I think might be helpful is if we approach life as somebody who doesn't use our services at the moment, and you went onto Google and you wrote in a few different search things, would that come up?
We're doing more and more where we're actually priming Google with service pointers, and actually I will take from this actually to do a double check around, making sure I think some of the key services are really coming up to the front of search.
What resonated with me was the point being made, because there's a website doesn't mean people can find it. So I'm just telling you what was.
During our winter campaign, we paid for Google search marketing activity, and that guaranteed that the search was really high for mental health, and we put that in there especially. Now that has come to an end. So to do an always on Google, because the trouble is they want to make money out of analytics and paid advertising. So we need to be investing in that significantly to make sure that really happens.
Okay. The point being made on this particular point. Yeah.
And just using when we're talking about mental health, Debbie, you referenced it, I think, about the importance just to really emphasise the well-being of our workforce. It's a very, very large workforce. And I mean workforce just as well as clinical, but non-clinical. And it's just we met with Doctors in Distress yesterday, and it's a charity that helps offer services for clinicians and non-clinicians, actually. And I just want to also point out, I think, the workload that general practice is under. And I know M and the LMC do offer quite a lot of support to general practice, but that's something that may I just wanted to emphasise that point.
Martin, on this point.
Yeah, because I think if I was to watch that vignette in isolation on the ICB website, it basically says, rung up the doctor, and I was told, yes, I do have to see the doctor for this condition, and I did have to go through clinic to make an appointment. So I think there's perhaps some onus on us just to make sure that when that's one of our vignettes, we put on a sort of correction or something on the screen and say, actually, if people don't want to.
Thank you. So we're going to go Ali, Neil and Emma.
Thanks, Chair. I just wanted to take a moment to mention a couple of the vignettes. I thought they were really good, and I quite like the theme that we've done this time, and I agree with Debbie that might be something that we want to do in the future. I think Hayley's story was really moving, and I was particularly touched by her watching back videos of her with her children and seeing the children smile and realising that her perception at that time wasn't right. And I thought the campaign film for Man Down and the impact that had for Tom was really powerful as well. But I did just want to take a moment to thank colleagues for taking the time to develop these films, because I think they are all really powerful, and this is every month they're really powerful, aren't they, and raising awareness of services that are available to our residents. But in particular, I'd like to thank our residents for sharing what is very personal circumstances with us and the rest of Cornwall, so that we can learn from them. So I just wanted to say that, really, Chair. Thank you.
Ali, thank you. Neil?
Notwithstanding the fact that Martin picked up the possible time gap, it's worth saying that if I look back in terms of resource for people, which now we're seeing is personalised and close to home in various ways. We used to often talk in primary care of the big gaps in mental health provision. And what we're seeing is that through these types of interventions, these gaps are broadly being closed. There are still gaps, but the degree of waiting and nothing happening for people that used to happen, because most people were going into what one would call statutory mental health services, and there was very little out there otherwise. This is a huge change in the last few years, and it's to be congratulated.
Okay, thank you. Emma?
Like everyone else, I welcomed the theme of it, and I just wanted to do a bit of an update, John, because since the conversation about talking therapies, I've met with some of Debbie's team, which was a brilliant conversation about how we can better join up services across all of our sectors, and I think that came through really strongly in the vignettes. There was a whole range of different support, so we've already picked that up, and I think we'll be able to do something really exciting about both access to, communication about, and that online presence.
Dave?
Excellent vignettes, all really helpful. The vignette on the transition from primary to secondary school made me reflect a little bit on transition for all of our services of children and young people into adult-focused services. And I just wondered whether there might be a benefit at some point in the future in having a focus on transition right across health and care. That might be useful to give us some insight on any themes across all of our services.
Cool. Good idea. Okay, colleagues, let's leave that there. Thank you very much indeed. As always, Lucy, excellent insights, and thank you to you and your team for doing that. So, actually, I'm just going to jump back at agenda item. I just realised that I skipped over, having done the minutes, I skipped over the actions. So, I'm going to turn to Molly. Are there any action updates that you need to capture?
Yes, Chair, there's one action relating to the 1-1 service. It was just a flag that it is actually incorporated in Steve's partner update. So at the time that we'd got before an update.
If we could try and close down actions as we go, that's important. Maybe next month we could spend a bit more time on that. Okay, so we're going to move to my chair's update. So rather unusually for me, I'm going to actually tease some of the bits out, because I'm going to hold myself to my own challenge, which is how we might celebrate some of the challenges and moments that we've got. So I do want to thank openly everyone for their support in getting the System Improvement Quality Committee off the ground, a genuinely new initiative across the whole country that Cornwall City are leading on. And I'll let the executive group talk about that more later on. But it's had its first meeting, and as somebody who attended that, my own personal view was that it went really well, really collegiate, challenging where it needed to be, and looking to make key decisions. So it was a great start. Some of the other themes we ought to just pick up on. Thank you, Simon, to you and your colleagues for getting us to not only a financial position last year, which you can now say is more formally 23-24 as a break-even budget, but getting us to a break-even budget for this year, which is a huge collective collegiate agreement to have got to that point. So I just wanted to celebrate that moment. I'll let other colleagues talk about some of the quality improvements, but it does feel that in quite a number of areas and key areas that we're looking at, we are making significant improvements on what we're doing. And Ali and Rachel, as you're here, we're so grateful at the ICP meeting to actually see Kate Canali talk so openly about us coming together. How do we investigate bringing the Health and Wellbeing Board and the Integrated Care Partnership closer working together? It's another step forward, which was really supportive. So I just wanted to reach out and say thank you to that. I didn't want that buried in some report somewhere. Just a couple of practical things that I need to get sorted as the chair. One is we have 4 statutory partner members. One colleague has already, I have confirmation that they'll be continuing from the 1st of July. There'll be 2 other colleagues who I've reached out to just need their feedback so I can get them formally over the line. But it's really to alert you all that subject to today, what we're going to be doing then is actually starting the replacement for the partner primary care and medical services director role, and that is a process selected by our primary care networks and our various medical services areas. So that process will be led by Kerno CIC, And I'm hoping that process will be out to market, if I can put it that way, after this meeting, Wally. Thank you. And then that person will be selected through that process back into here. Kate will organise a proper process to go through internally once those nominations have been made, and then I as chair can appoint them, and they'll be here for the 1st of July. So I just thought you ought to be cited on that process. In my report, I'm also in the process of setting up two things. One is an associate non-exec member. There's an element of succession planning which is at the heart of that. Think about the way in which 42 integrated care boards were done. Unusually, they all started on the same day. So there is an element of needing to stagger. I know we did stagger some of the terms of some of the non-execs, but we could still be in a situation, if we're not careful, where we suddenly end up without that. So that it's a pretty well-trodden path, the associate non-exec role. So with your support, we'll look to go to market to find an associate non-exec. Although I've badged it as linked together, they don't have to be linked together, is the concept of actually having a lived experience board. The idea then is once the non-exec, associate non-exec is appointed, is that that individual will then work with all the key players and partners in the group to form what is the right cohort of people that would actually be on that. And the idea behind that, as I say in my chair's report, is that they will look at the public part one board papers and give their perspective from it. Because I think it's quite easy for us to get an element of corporatitis, if I can put it that way, and use our speak and whatever. And really, we should be having a lot more representation as to understanding as to what patients and our citizens and residents actually have a view on. So that is an ongoing process, but I thought we'd just flag it now. That's another direction of travel, like with vignettes, of trying to actually get people who live in Cornwall and Aylesbury actually feeding directly through into this board, and we hear them. And using that associate non-exec will be part of that journey. So thank you, Kate, as also for supporting that concept. Okay. So the detail of that is still to be worked up, like I say, but I just wanted you to note that I was in the process of setting that up and cracking on with the associate non-exec. So unless there's any other comments, I can just receive my report and note what I've just said there. Is there anything else? Debbie?
So I really welcome some forward thinking about succession planning, and certainly we've really benefited in our board from having associate and non-executive directors, because that provides an opportunity for people who might not have the experience, but they actually have a lot of lived experience or aptitude in particular sectors that can really be helpful to us in the NHS and more broadly system working. So I really welcome that. I note that you've linked chairing the lived experience board to that associate NED, and I just wondered whether that was an intentional link or whether it was a potential link, Chair.
That's why once I'd written it, and like the value of having papers out early, and bearing in mind I had circulated this to the non-execs in advance and to Kate, etc., and other colleagues. One of the comments that was made to me in between the paper going out was, well, there was a number of questions about the cohort, whether actually we were going to pay people to attend, a whole raft of other things. And was I linking it directly to the associate non-exec, which is why what I was trying to summarise was that was my original intention. But if when we appoint the person, it doesn't feel inappropriate as we develop this concept, then we will work together to find out the best way to do that. What I'm trying to avoid is actually having 30 people again. And what I'm also trying to avoid is actually having the cohort of non-execs who are already doing a huge amount of hours, more than probably they're doing, how we actually get some bandwidth, and what does this role actually, as associate non-exec, actually help us with, given the fact they're an advisor to the board and not a member of the board, which is an important subtlety.
Thank you.
Okay. Happy with that? Stuart, yeah.
Thanks, Chair. It's just to give my support for the concept of a lived experience group. It's certainly something that we don't do enough of in healthcare. I've seen it work very powerfully with colleagues locally in our mental health services, and it is just such a positive thing. You're right, there can be a complete disconnect with what's said in boardrooms and what goes on in communities, and so now I'd welcome the community health worker as part of representation as part of that, as per your paper. because again, I think it's in all of our duty to support the inequalities agenda, and they'll be well placed to do that. So thank you.
Thank you for teasing that out. That was a deliberate, as we're now investing in that group, to get their voices heard directly. Okay, thank you. Let's move on. So Kate, over to you.
Thank you. So there's quite a lot in my report this month, so I'd just like to bring attention to a few matters. So the operating plan is going to come up on the agenda a lot, so I won't say very much about that, but except to say thank you to everybody for their time, effort, patience and resilience to get through to the point where we've got a balanced operating plan. There's a great piece on the second page of my report around our system performance improvements. So it's clear to see that we are sustaining improvements that we've put in place across the last year. But it's also time, I think, for us to start to reflect on, if we were looking at next year, what would we be wanting to measure? And maybe we should be looking more at outcomes than we currently are in terms of inputs. And as an executive, we had some time out earlier this week, and we were thinking about things around our Start Well component of our integrated care strategy, and how we could start measuring resilience, because the discussions we've had around mental health, so the resilience of individuals and communities. So that's something that we'll come back to over the next few months. We had a national visit, a national and a regional visit to the same-day emergency care frailty service at CFT, and I have to say, also on Debbie's behalf, people were blown away by the service that's in place. And in the pack today as an appendix is the outcomes that Janine Glazier, the Associate Medical Director in CFT, has been pulling together around the services that they're offering across the whole of the community trust. So lots of national support for the work that we're doing, and hopefully as we go through this year, we'll be looking at other places across Cornwall and the Isles of Scilly where we'll put frailty SDEX. Debbie and I are also meeting with colleagues from around the country around integrated neighbourhood teams. So Stuart Smith has made contact with the National Association of Primary Care from a central and mid relationship. We've met with the National Association of Primary Care, and we're going to form a learning set with people across the country, and we're hoping that will support the work that Mid and Central are doing, but also excuse me, the West ICA are wanting to start to look at ways in which living well or live well comes back into being the way that we do work in the west of Cornwall. So really exciting. And what was really nice for me, because I've been here for 7 years, and Debbie, because it's her services, was the reflection from colleagues about how much progress we're making and how much enthusiasm sits within our community services for significant change. So that was great. Community Hub celebration event. If you ever want to have your feel good batteries recharged, please go and talk to our independent sector colleagues who are doing so much around our county, and are so eager to tell us around the massive value they make on a day-to-day basis. So we've sustained our investment in the community hubs this year, but it is something we need to be looking to develop further as we go over the next few years of our integrated care strategy. And then I think that's probably all I'll pick out. So the NHS England event, Steve wasn't able to go, but Debbie and I were there, and Robin, who's the Chief Operating Officer from RCHT, was there. One of the really refreshing discussions we had was how quality improvement and continuous improvement should be driving our ways of working over the next year. So we've already asked Ella Stracey to make contact with Tracy Lee for us to start looking at how our quality improvement methodology gets shared across the county. And as we go through our redesign, we will be making sure that all of our transformation support hub team are all QI trained and change management trained, so that we've got more people across the county that we can turn to manage big pieces of work for us. And then the last bit of brilliant news is that we have been awarded one of the Work Well schemes for the next 2 years. And I'd just like Patrick, so Patrick's done a piece of work with our local authority colleagues, brilliant for Cornwall, brilliant for our people. Would you like to comment?
Yeah, well, thank you, Kate. So yeah, it is great news. We're one of 15 ICBs in the country to be awarded Vanguard pilot status through the Joint Work and Health Unit at National national government. So that will see us pilot a new approach to providing support to people with long-term conditions and disabilities to access and stay in work. That's the fundamental aim of the programme. And I think our bid was very strongly partnership based, and I think that stood us in really good stead. Cornwall's done a lot of good work, especially the economic development team in the council and public health in this area. So we were able to demonstrate how we're building on that work. And we had letters of support from local authority, Chamber of Commerce, voluntary and community sector, all of which were bound to have stood us in good stead. So just to highlight 3 immediate actions. So firstly, the Joint Work and Health Unit, which is DWP and Department of Health and Social Care, will be working very closely with all of those vanguard areas. So we will be establishing relationships with them in terms of program design, and we'll be doing that alongside the other 15 pilot areas. So we're waiting to hear further detail about the delivery arrangements for the programme, but we wouldn't anticipate any service being up and running until at least October. So just making sure that we're aware that we've got a lot of design work to do before a service starts. And then next 2 actions in that regard. So we'll be recruiting the ICB, looking to recruit a 2-year fixed term contract funded from the award for a work and health lead role, which will be a role that we've probably felt we need in this system for a while, but not been able to finance. So this programme enables us to do that. So that will lead work on work and health more broadly across the partnership, as well as have direct oversight of the Work Well programme. So we're looking to move on that in the next few weeks. And then we'll also be mobilising early part of the design work. So a lot of people will have contributed to the work that developed the bid, and we'll be now picking that up in earnest as we start to do the work on the design. And then last but not least, establishing the programme governance, which we're going to need to take a good look at to make sure this is properly partnership owned across our system. But yeah, great news and a lot to do and good to get going on that piece of work.
Congratulations, really well done. Yes, I can see. Ali.
Thanks, Chair. Well, first of all, I just want to say thanks to Kate for such an upbeat and detailed Chief Exec update this month. And I just wanted to congratulate all colleagues that were involved in the Work Well bid, because I think that's been a fantastic partnership piece of work. And it is really good that we're now going to be able to take that forward and make such a difference to all of our residents, but particularly for those that are disadvantaged and disabled. So I think that's fantastic. I think the community hub celebration was fantastic. And I was really grateful to have the opportunity to go to that and see some of the outstanding work that is going on across our communities. And I'm just sticking with the theme, John, of celebrating some of the things that are working really, really well in Cornwall. So you have to indulge me a little bit, but I thought it was really good, Kate, to see you pulling out those specific areas of improvement and progress across the system, which is really good reading. And I thought that was reflected in all the papers today, actually, the progress that we're making as a system. And then just when Kate mentioned about thinking about what the ambition is beyond this year, I just wanted to share with the group that the Care and Wellbeing Directorate in the council, we're having an ambition setting day in a couple of weeks. So we're looking at the public health outcome framework and the adult social care outcome framework and setting our ambition for the next 3 years. And I just wanted to put on the table that it might be something that after we've done that internally, that as a system we might want to come together and think about what our journey is over the next 2-3 years and what that kind of ambition is that we're going to deliver on, and link that back to the legacy conversation I keep banging on about. So apologies for that as well. Thanks, Chair.
Don't apologise. Keep going if you want to. Great ideas,
No,
all there. Will you pick up that, Kate, with Ali?
I will do. So if we pick up offline.
Ali, thank you, Mary.
Yeah, thank you, John. Absolutely echo everything that Ali has said there, and real congratulations. This is a very big step for us all, and it's going to be a really useful one in our communities, I think. So forgive me if I've missed this. I'm just wondering how the picking up the governance, Patrick, how is the governance of this scheme going to link through to the ICB board?
Yeah, so the programme is hosted and financed through the ICB. So we will be reporting we'll have the obligation to report through the board on progress. What we have to make sure we're getting right is in the partnership arrangements that we're reporting to the respective organisations and ICB and ICP governance, because this, I think, will sit very well under the Live Well part of the integrated care strategy. So the detail of the programme reporting as opposed to the organisational reporting still to be worked through, but we'll definitely make sure that there are updates into this board on progress along the way.
A suggestion there, and Tanya, no, I'm looking at you on this, as you chair the workforce committee that covers system, NHS and the ICB, it might be an idea, taking Mary's challenge there, just at the next workforce committee, if you could just have clarity on our collective behalf, and then you can assure the board when you come back that everything is
Absolutely. We'll keep over that.
Happy with that?
Thank you, John. Thank you.
Thank you, Mary. Excellent. Tracy.
Yeah, it's fantastic news and really great for the people of Cornwall, and I think it links really well with the mental health discussion we had earlier. I think with all of these schemes that are short-term funding, we need to be thinking right at the beginning about how we sustain this beyond the fixed-term contract that leads that work, so we can continue and have a legacy coming out of it, which continues for those people. So we'll just need to pick that up, I guess, and be assured that we're doing something that can be sustained.
I'll just comment very quickly on that. I think a key principle of the bid and for our work is going to be real-time evaluation of its effects, because that will effectively form the business case for whatever follows beyond the programme period. Debbie? Agree.
Yeah, so two bits. First of all, I'm delighted, Patrick. Well done to you for pulling it together, because these things always require midnight oil at the last minute, don't they? So thank you. Again, we'll share it with Lucy, but we had a showcase at our board yesterday for Project Search. And certainly that's a project that both CFT and RCHT have, where we're supporting young people with special educational needs and disabilities into work. And again, it was one of those fabulous case studies of what it meant to the 6 young people that had 6 weeks on placement at Bodmin Hospital. So again, I think we can link in with the vignettes, but also this piece of work, because there are already some elements in place. And then separately, could I just give a really big shout out to the ambulance service? I don't think SWAST are here, but I'm very grateful for Kate's kind words about the frailty SDAC, and it's our staff working in partnership with RCHT. We're now seeing versions appropriately from UHP, but the ambulance service, when I was in the unit yesterday by 1 p.m, already taken 9 calls from the ambulance service directly. Now, not all 9 need to come in, because we've got community nurses there. They are able to then say, actually, we think that one's for virtual ward, this one's for UCR, but it's that really real-time interface that's working. But a big thank you for SWAST, because they really have embraced this new model.
I'd endorse that. Did Neil follow up directly with you?
Yes.
He did. Because there's something about the SDECs there which are at the heart of the solution, aren't they?
Yeah.
Thank you.
So we've seen a sea change.
You have. Happy days. Well done.
I just wanted to pick up the work well bit about employers. So I think that we're going to have to do an awful lot of work with large employers across Cornwall and the Isles of Scilly about how we have an environment where it's okay to come back to work if you've had long-term health conditions or long-term mental health problems, or both. So I think during the early part of this project, I'll be wanting to see what environment our employers are creating for people. Because I think there's a young man with a learning disability, he's called Harry. I think it's called Harry's Challenge. He came to the chief execs in the Southwest, it's probably about 2 years ago, and he starts off with, you have the power to help me live longer. Because the link between people with a learning disability or a long-term condition in meaningful employment means that their health is better, they're happier, and they generally have much better lives. So we've got a massive opportunity, haven't we, to make a big difference through this project. So it's great news.
Okay, thank you, everyone. Let's move on. Okay, thank you. So that's the Chief Exec's report. So I'm going to go around the committee chairs first of all. So Martin, can you do a double hatter here? Could you I don't think there's anything from the audit committee to update, is there?
No, we had no audit committee meeting this month.
Sanj isn't here. In terms of the finance and performance committee, can you give us a perspective on FNP, because you considered the budget and that kind of thing?
Yes, so the most recent meeting was the one before the extraordinary board to approve the operating plan that I know we're going to come to. But so the committee went through that work in some detail, congratulated in effect the system on achieving a balanced budget, and I suppose balancing the operational plan to the financial plan, which is the real trick, because we have to achieve both the targets and the money, of course. As you'd expect, being an assurance committee, quite a lot of time spent on the risks to the plan. I guess on the operating plan, Sandra was particularly raising in the report things like the waiting times, 65 weeks by September, going to be difficult to achieve. Obviously, the usual ones around ambulance waits and all the rest of the targets, basically, those particular ones are some risk we felt. In terms of the money, I think the one thing that Sanj wanted to highlight was that the committee feels it will keep more of an overview on delivery of savings, CIPs. There's quite a big savings target this year, not all of it yet fully allocated to schemes. And we need to really monitor that early and get in early if there's any deviation from the plan, because, when I say early, we're already in May. The longer we leave it, the less time to deliver and the more problematic it will become. So the committee is certainly going to keep an overview on that for the system and, see if we can take corrective action as required. But overall, very positive meeting, very glad that we'd achieved the budget for the closing year as well. So a great result on both those things.
One of the things that he's asked me, and I'm very happy to support on, is that in order to keep the board abreast of all of this, and I know, Simon, when you and I and Sam spoke about this, because it's month one, not been able to do it for this one, is that we will have a regular update from FNP structured in the agenda to actually look at SIPs most specifically, hopefully to celebrate their continued success and whatever. But if not, we get early sight on where, what and why things might need some support.
Absolutely.
Thank you. Tom?
Just a brief addition, John, in terms of Workforce Committee, just to say that at the next Workforce Committee, we'll be reviewing the IPR dashboard for workforce data. We will be bringing something back to the next board with that.
Very much. No.
From the Quality Committee point of view, just one thing I would like to highlight from my report is we took the annual update, end of year update on emergency preparedness, resilience and response. And of note in that, the committee heard that in terms of industrial action, if you add up days before and days after, 100 days had been affected last year by industrial action. However, only one critical incident had needed to be called. But the thing that I'd like to draw attention to partners in the system is the importance of ensuring attendance at debriefing sessions. The sharing of learning is key to best practice in this area of work. So it's really important to make sure that partners make sure people can attend the debriefing sessions. In terms of the new System Improvement Quality Committee, the Quality Committee for the IC Board welcomed that opportunity and will work together with the Chair of System Improvement Quality to ensure that the statutory work that needs to happen at our Quality Committee can continue, but how issues that come up inform what we might take to System Improvement Quality Committee, and therefore look forward to efficiencies in the way that we work both committees. Thank you. And in terms of the ICA committee, can I just mention that we did receive a very welcome report on the evaluation of social prescribing, and the importance of this work over the last few years was highlighted in this report. And the committee took forward an endorsement that there needed to be clarity as to a strategic lead for social prescribing, and in the future ongoing funding of what is a key coordination role to looking at how we maintain social prescribing. So I just wanted to raise that as an issue for the board.
If I bring in Emma on the screen, Kate, can I just be clear on how the vision for social prescribing aligning with the community health and wellbeing team? having spoken to Mr. Brazil, I forget his name, Matthew
Harris.
Matthew Harris. What's your vision for how those are complementing each other?
So I think there's space for both functions to work across Cornwall and the Isles of Scilly. I don't think we've got a named individual for social prescribing. I was looking at Emma as you were talking, so it's maybe something for me to take away and to bring back to the next board about how we maintain the oversight of all of the different ways in which we can contact everybody we need to across our county and the islands.
We could take that to action. That'd be grateful. Thank you very much.
I'd agreed that Chris would take forward this particular work and how we would achieve that.
If your committee does that, and then the board's asking Kate to pick that up as well. Thank you. So Emma on the screen.
Thanks, Chair. Just picking up on Neil's points, really, and specifically in Dr. Sant's absence, just to re-emphasise the point that's in his update around GPC being in dispute with NHS England formally, and what that might mean over the course of the summer months in terms of, excuse me, struggling with the cold at the moment, collective action or industrial action from a general practitioner point of view. So we will continue to keep the board informed of anything that we can share, but certainly that is something that will have an impact on the entire system if that is wide-ranging.
Thank you, and please keep us updated on that. Stuart.
Just a point of clarity around the difference between a social prescribing link worker and a community health worker. A social prescribing link worker is somebody who sits at the interface between health and community voluntary sector services and supports people to access those services. A community health worker is somebody who is deliberately going and targeting households in our poorest neighbourhoods, and really the two make part of a comprehensive place-based mental health team, really, or MDT. So just important to draw the distinction between those two roles, that they work together. And I think oversight currently for both would be via Volunteer Cornwall with Julie Pollard. So I'd suggest you reach out to her.
Okay.
So as a commissioned service, it would sit with Julie Pollard. So one of the things that I think, Stuart, we need to look at going forward is, because this is working, isn't it? So the services that we're putting in place are working. If we started measuring community resilience in places that we've got these services, and I don't know how we'd measure it, but I'm sure there is a way of doing it, and Rachel could tell us, we'd probably start seeing more community connectedness. And once we start seeing that, we know that we'll get better outcomes. So I think over the course of this year, we should be making some decisions as a board about how and where we make additional investments into these sorts of services, but being led by our places. So that's why I gave a bit of a, we'll take it away and come back with the answer, because I'd want to talk to our place directors to be able to start telling us how we take this forward, and also how we employ people. So I don't know where, because there are different forms of employment as well, aren't there, for different social prescribing roles and the community development workers. So a big piece of work to do, but I think we should be wanting to do more of this to be able to support everything else we're doing.
To try to bring in town, I think the assurance I was certainly looking for is just making sure that, this is my language, that the left arm and the right arm know each what they're doing at that level, and they're not double bubbling, they're actually working together, and you just need that assurance.
And measuring the same things, John, as well, would be interesting.
Over to you.
So just to reply to Emma's comment about the challenges that GPs are going to be facing over the summer, just to give assurance that we have got that in hand now in our pattern of PCCC meetings that have got a plan of action across the summer. So we'll pick that up there and report back to you here to give assurance.
Thank you so much. Yeah.
So in terms of the potential for industrial action as part of general practice, so we need to give exactly the same lines as we gave for hospital doctors, that we support the fact that our GPs have got the right to take industrial action if they get to the position where they feel they need to. That said, we need to make sure we've got a safe county. So we would want to be working with general practice about how we are making sure that all of our residents can get the care that they need. And we also know that for some of our residents, the default into ED or an inpatient setting is the wrong thing for them. So we'd be wanting to build that into our plans. And thank you, Emma, for raising it early on, because it also then gives us an opportunity to talk about how we support general practice leading up to that point. So it's really helpful. Thank you.
Very good, thank you. So let's move on. Nick?
Yeah, thank you, Chair. There was no additional thing from PWP. We haven't met this time round, and I think I have an update specifically on system quality improvement later. So I have nothing else to add at this point. Thank you.
Thank you. So I'll just go around the statutory partners now. So if I can just look, Ali, anything from yourself?
Yes, Chair, if that's okay. I've got a few verbal updates as the reporting didn't synchronise for us this month. So just to update colleagues, that Cabinet received an update report yesterday at Cabinet on the 24-25 budget, and there's a number of in-year adjustments, really reflecting the demand management strategies that are being put in place, particularly for children's services, emergency and temporary accommodation and school transport. They also received a business case setting out our intentions around extra care housing and care homes, this was excuse me, this was a business case delivering on our kind of Cornwall supported and specialist housing strategy, and the proposal is that we'll open an 8-year framework agreement which will enable us to enter into long-term care contracts and look to work with both building development companies but also care providers moving forward, looking at extra care and care homes. The Cabinet also recommitted to the local authority declaration on tobacco control, including the ambition to create a smoke-free generation by 2030. There was a really excellent paper from Rachel Wigglesworth's team at Cabinet yesterday, which I would recommend. But one point that I did just pull out from that paper, I just wanted to highlight that the financial consequences of smoking in Cornwall in 1 year, 22-23, was estimated at £151.2 million, which is astonishing figure. And I also wanted to mention the Strength and Balance Falls Prevention Service, which Rachel Wigglesworth's team has been commissioning and rolled out across 12 areas in Cornwall. It's very evidence-based interventions to prevent falls, and hopefully we'll start to see an impact on this in future years around fractures in the county. And then just one more thing from me, Chair. Adult social care, the operational team, we're currently engaging with colleagues across the service around the leadership structure. This is following a number of vacancies within the structure, but also looking to make sure we've got the right capacity and capability across the leadership team to deliver our functions, and also to make sure that we've got the right structure to support the mental health services, which have returned to the council in June last year. So that's just a highlight report from me. Thanks.
Okay, thank you very much. Of course, Andy is not here with us today, so I'll move on to Debbie. Anything you want to add?
So there is no report this month because we've got a deep dive. So, and I think given we've already celebrated Mental Health Awareness Week, there's nothing to add.
Thank you very much. Steve, anything?
Just a couple of things to draw out of the report. There's a lot of information in there. But firstly, to acknowledge the urgent emergency care improvements that are outlined in the report for April. We did see a significant and sustained for a 4-week period improvements, and there's some information provided in what that meant in terms of significant reductions in ambulance handover delays, significant improvements in category 2 response times. That's a reflection of a huge amount of work across the whole system. Ali, we've seen, and Kate, a significant reduction in no criteria to reside patients waiting in hospitals for some form of onward care. So really positive and welcome to see that. We've already touched on the example of the frailty same-day emergency care service at Bodmin, really significant in reducing potentially avoidable conveyances to the emergency department. Significant work from SWAST, from colleagues in Royal Cornwall Hospitals, NHS Trust, and right across our system. So very welcome and a significant step for us. I should note that in the first week in May, we have seen performance more challenged coming out of the bank holiday weekend. So we need to take further steps to address that and see that performance return to what we saw in April. So certainly we have a long way to go, but firstly to acknowledge that improvement in April. And then just to draw out a couple of the things from the report, given you talked about celebrating successes, the Learning Disability Service accreditation, the first of its kind in the country, is really positive to see in terms of that community services accreditation. The orthopaedic super clinics that were undertaken were really positive. I had the opportunity to join colleagues during the start of that first super clinic on the Saturday. So great feedback from patients and good to see. The pop-up community imaging services to provide more access close to home for skin cancer services. The Kerner Health CIC training hub, whilst there is a funding challenge, the impact that that's having around GP support is really welcome to see. And there's a detailed update on NHS 111 performance, which of course is an important part of our wider urgent and emergency care services. So whilst there are a number of challenges, that there is a huge amount of work and success being progressed right across the NHS provider sector. So happy to take any questions on any of those.
Thank you very much. Stuart.
Yeah, thank you, Chair. Thank you, Steve. I think, and congratulations everyone on the improved emergency care data. You know, that is definitely something to be celebrated, isn't it? I would say that for the first 3 months of the year, in my own practice, which is 40,000 patients, we've seen a 7% increase in demand on our services. And I just again want to highlight some of the fragilities in primary care, where I think we're everybody would admit that we're probably holding quite a lot of this extra risk and frailty. And I'm sure Emma may be able to elaborate, but she's been working with colleagues in CQC who are struggling with in terms of CQC this over the last week, and previously very stable practices are showing significant fragility and issues. So again, just to raise this, just another point, if that's okay. There's a distinct lack of data on my community service colleagues in this report. And I just think when we've been doing the neighbourhood teams work and going around the various PCNs, and these people are doing so much work in terms of keeping people out of hospital. But one of the familiar feedbacks has been quite low morale, significant staffing problems. And we talk about parity of esteem quite rightly with mental health. I just feel like there is very little data or reporting on our community service colleagues in terms of nurses or reablement services in the report. And I just welcome any views of whether in the future we might be able to include some data or information or updates on those really valued colleagues who are absolutely key to delivering out of hospital care.
So Stuart, can we have a discussion about how we do that? Because I think, so Debbie's team have been looking at how they show the increased productivity and the efficiency of community services through what they do. But I think through the work that you've started with the National Association of Primary Care, and that the West are starting to look around their integrated community teams, neighbourhood teams, it might be helpful for us to look at how different parts of Cornwall and the Isles of Scilly are supporting their residents through the services that they're knitting together. And it might be a bit more than a partner update, but I think we need to work out how we reflect this in our reporting going forward, not least of which is because it provides systematic and solid support to general practice.
Okay, if you can take that as an action, Kate will take it away. Emma?
Yeah, just very briefly, Chair, to pick up on Stuart's point, thank you for raising, just for citing really, and so that colleagues can understand how what happens on the ground with CQC inspections, which are occurring fast and furiously at the moment, both re-inspections and new inspections. We've got a massive cohort of GP practices that have not been inspected for a number of years and are overdue just because of cycle pressures, I guess, within the CQC and their reorganisation. So we are being pulled from an LMC and ICB colleague point of view into support for those practices quite intensively. And as Stuart has alluded to, it's showing significant resilience issues for practices right across the piece at the minute, which is probably, certainly from an LMC risk register point of view, if we had one, probably one of the highest that we've got at the moment. So we will work with ICB colleagues to get the sort of the nub of those things and what we can do to support escalated so that there's citing by the board here. But I think it's just another element to be aware of.
Okay. Steve, did you want to come in?
Yeah, if I can, just to come back to Stuart's questions. Thank you, Stuart. Certainly welcome them and welcome Kate's comments as well. The NHS partner provider member report focuses on SWAS, CFT, RCHT, UHP and Kernel Health CIC. We have up to now had separate reporting arrangements from a primary care perspective. So I'm certainly mindful of that, but also mindful, Kate, as we move more and more on this integrated care journey, that then separating out our reporting or feedback mechanisms, I think, becomes more challenging. And Frailty Services, I think, is a really good example, which is a system-wide set of actions. So that might be something for us to reflect on in the future as we progress in terms of what might sit in individual partner member reports.
Before I bring in Stuart, one of the things that might answer your question, feel free to ask another one in a second, but part of the reworking of the statutory partner role that we're just about to go out and seek for primary care and medical services, that report, I would expect to start actually having much higher degree of contribution from all the things that you're talking about than possibly we've had before. So I think there's a bit of a reworking to be done. But Stuart, you had your hand up first.
No, just for clarity, I am talking about CFT employed staff here. So we're talking about district nurses.
Oh, lost you.
Sorry, for clarity.
We can't hear you.
For clarity, I was talking about the for CFT employed staff, particularly district nursing colleagues, reablement colleagues.
Okay.
Chris? Just on the point that Stuart was saying about the amount of work that goes on in the community, in primary care and in general practice, and how that keeps people out of hospital, I think it's important to link in the work we're doing with Arden and GEM, which is a long-term condition modelling tool, because that tool, when used and supported with general practice, will help showcase exactly the impact that this is making. So I'm just asking Stuart and the GP Collaborative for his support in that.
Okay. Neil, and then we're going to move on.
It's just to make a point that at the Integrated Care Area Committee, there was a discussion about the future, the current and future importance of the way that integrated neighbourhood teams work, and the differences across the county that have already been alluded to in the way that they develop. And some of that is aspirational and some of that is sheer reality in terms of who's available to be part of integrated neighbourhood teams. It's just a plea that's been put in at the committee is that the way that they develop is allowed to be from ground up, and that not too many constraints are put in by the system as to an ideal model of an integrated neighbourhood team, because that could work, but it could backfire. And it's just being careful that people within the system and partners working who provide members of neighbourhood teams don't try and dictate the way that happens. It should be a collaborative approach.
So at our exec time out this week, we had a discussion around how you govern place. My view is we do it through the roles we've put in place, the integrated care directors, but place decides what's right for place. And that organic development that has happened over probably 7 or 8 years is now starting to be codified into something that we can see and see the teams forming. So I don't think we have any intention as a board to impose it should look like this structure, because we're making so much progress with the people that are nearest the problem, sorting out how they're going to deal with it. Is where we've got gaps. I think I spoke to Stuart's point and Emma's about how we make sure these are resilient teams that we are putting in place who are able to do the job for the future.
Okay, so last comment.
So I welcome it. I think it'd be helpful to kind of understand a bit more whether you're seeing those challenges now, and in which case we can take some action. But I'm also mindful, if we think of the Frailty same-day emergency care service as an example, I do think that there may need to be an element of consistency in a West Cornwall model, in a Bodmin model, in another location models. So I could see that we could have a kind of a dialogue and potentially some tensions in some areas between how much do we need these services delivered in this way and how much can they be tailored locally. That feels like that would be quite a healthy discussion for us to
Where does that
have.
take place?
So I think SEG's a great place for it to take place, and the clinical reference groups, because then place will be represented in both, because it's sort of the covers the whole of Cornwall, is available very locally, and then the things in the middle that allow the both to work. And we just need to make sure we land the right things in the right
Do you think
places.
it's too soon to try and get clarity at next month?
I think we just need to, I think we know that so Steve's point about SDEC is really well made. We've got a model that works. We have no reason to believe that model needs changing to work somewhere else. However, integrated community teams will work according to who's in them. So we just need to make sure we've got the right way of working for the right
Have all
service.
the 3 place directors started working yet?
We've got one that starts early June.
The other 2?
The other 2 are in place, ready to go.
So they're in place? Oh, okay, so we're two-thirds there. Okay, lovely. All right, thank you.
I know you want to move on. I think that the points that have been made, I think the other thing that we need to do if for place is to look at our outcomes, because then we will build our services around the outcomes. And that then, Neil, means it can continue to go from bottom up. But I think as a board, we have that responsibility about the outcomes of our population and tailor the services to that.
At the risk of either delaying or upsetting anyone, people are always happy to say, can I do what I want? They all need to be accountable to then for the outcome. So very happy for people to say, can I own this project? So long as they then deliver and take it forward, they need to be held to account for that as well. Yeah. So let's move on. So Mary, you've asked to say something.
Yeah.
So
Thank you. I've got a few bits I want to bring to for information, a few challenges and risks, and a couple of celebrations. Just to let you know that owners and managers of supported accommodation for 16 and 17-year-olds from the end of last year now have to be registered and regulated by Ofsted. That may not be something that people have been aware of previously, because previously it was unregulated, apart from the council's input. Funded nursing care and continuing health care. I've been asked to stress the fact the nursing home sector are being left short of funds because people are coming out on a discharge to assess, asked to go and assess for a nursing bed, and after a short period of time being reassessed as not nursing. And I understand from the stats that have been sent that we're a little bit of an outlier down here given our demographics.
who's assessing them?
The nursing needs assessment process. So if they've landed into a nursing home, then there needs to be some sort of a process. There is a process, but because people are failing to meet the criteria for nursing much more frequently now than has ever been the case before, some nursing homes are struggling to continue to pay their nurses. And that, of course, is putting extra pressure, or could be putting extra. Do you want to go now?
Yeah, so helpfully, Mary, I've spoken with NHS England, because you're right, we are an outlier in terms of the amount of people that we give funded nursing care to. But when you start to look at so I think we're about 5%. The national average is around 16% of people are converted into funded nursing care. When you look at our denominator, it's large. So we need to get back to the root of the issue of how many people are referred into funded nursing care who then we find don't need it. So we're making the appropriate assessments. It needs to come further upstream. So I spoke to our relationship manager, Ram Subamaran, who has picked up community and is overseeing CHC, just to start to get into the reasons why we're referring so many people to funded nursing care who actually clearly don't need it. And then I think we need to pick up the other issue, Mary, of the funding of nursing homes, because it's a service we need. We just need to use it appropriately. So I'm aware that we're an outlier. We will be having monthly meetings with NHS England to go through our actions.
Okay.
Really
Thank you, that'd be good to pass back. Residential homes, it means residential homes are accepting increasingly complex people, but some are not able to cope with more complex people when it's particularly dementia. So that obviously falls into their staffing levels. And it's just to flag up that there is a slight risk that some people are looking at their future, which may not be in time for some of the new proposals that are coming up with these new strategy for market shaping. But I can talk to Ali offline separately for that. There's a very slow rollout of the new framework for inspection from CQC. So providers are seeing that as a threat at the moment. They're seeing a lot of things as threats, and it's only appropriate that I let you know that here. For example, post-Grenfell, there's been a new flavour to the fire audits that are going around care homes, with far more conditions being required, particularly for more night staff, because they are looking at the dependency of the clients in homes
and telling, as an example, a 25-bedded care home that they would not be able to evacuate the people that they have living with them, and therefore they need to double their night staff. Well, one more night staff is about £50,000 a year. And if you're being told you've got to double it to 2, that's 100,000. In a 25-bed care home, that's another £4,000 per bed. So we need to have a joint discussion about what's happening here, because the care homes are being left by these fire audits, which CQC then want to look at with a great deal of concern. We're still seeing some revocations of licences for sponsorship, and we have insufficient sponsors with enough vacancies to take over some of the stranded workforce, or more probably because there's a lack of accommodation close to where the vacancies might be. We'd like to say thank you to the council and celebrate the fact that we had another £50,000 for care coins, just as Ali's disappeared, which we use for counselling and for mental health first aid training. And it's absolutely providing a huge resource that is keeping people in the care workforce, because they can get almost immediate counselling online, and it's working. We've had a very successful relaunch of the Registered Manager Network breakfast meeting, which had sort of disappeared. We've had some excellent speakers, from the X-ray car to the police, with others in between. Maybe we could have, Susan, we could have somebody from Discharge to Assess. That'd be great. We've had funding for that from Skills for Care, and we've had a small offer from the council. It's not cheap to put on a breakfast meeting for people coming from across the county. We need a venue, and we need to give them something to make it worth them coming for. So any contribution to that would be most welcome. And we're looking forward to the visit from the Chief Nurse for Social Care to Cornwall. Thank you, Susan, for including me in that. But it's social care, not NHS, so great.
It's a joint visit between Deb Sturdy, who is the National CNO for Social Care, and Sue Dehenny. So they're due down on the 14th of June. So
we've got the date, have we?
We're pulling together an agenda to make it a worthwhile.
Take it you're there with them.
Yes.
Thank you very much. Okay, thank you. Yes.
Can I just pick a couple of things up, Mary? So one of the things you raise around the economics of running a care home in Cornwall and the Isles of Scilly. I don't know whether, Ali, it's something that we could pick up between us, because we have got a lot of small providers in Cornwall and the Isles of Scilly, and we know that small providers will be more economically affected by changes in specifications or expectations. And I don't know whether that is feeding into the work that Rachel Rothero's doing, Ali, in terms of the future face of residential nursing home care in the county. But I think it's something maybe the ICP should be picking up and having a discussion about. So Tracy, could we pop that on the ICP agenda? And then my other point was around a venue, and of course we'll help you with venue costs. So we'll just take that away. If Simon doesn't, where is he? Can he see me?
He's here. Okay. Thank you very much, Mary, and thank you, Kate, for that. So, colleagues, let's move on.
Must be another Simon here.
So, in my eagerness to celebrate, I'm letting myself and you down in terms of timekeeping. So, I'm me is me, so I have to bring us back. It's the tick in me that wanted to make it happen. So, because Sanj isn't here, I'm going to just pause and look to Molly and Kate. Is there anything on and Patrick? Is there anything on the remuneration committee that Sanj would have brought that we need to have here, other than saying Sanj chaired the committee? No.
So do we need to reflect the phase 2 discussions that we're now going into the process of rapid recruitment, and that the Remcom oversaw the phase 2.
Oh yes.
But we're now moving to workforce committee, making sure that we go through phase 2, finish it, and that our phase 3 pieces of work are all fully.
Just note the fact that this board is empowering on phase 3 of that. The workforce committee.
Yeah.
If we could just minute that, that'd be grateful. Okay, so that's brought me back a bit of time. Thank you. So now we're going to move on to the IPR. Now, what I'm going to do here is I'm going to ask Kate just to do a 2-minute introduction as to where we're going on IPR, because I think it's still work in progress. So at what point will that evolve? And then what I'd like to try and do is start Patrick after that, because Patrick, I think there's something here about there isn't much in here in the workforce, but you've got. I'm going to turn to finance because there's a lot of stuff on finance that's covered elsewhere. So maybe say what you need to say, but there is an operational and budget section, so you might want to cover that off. Susan, the same from your perspective as we go through that. So please think about, we can have this in this debate or in the operational and planning budget debate.
Yeah.
Possibly, I'd like to try and have it more rounded in one debate under operating and the plan, but you choose. So kick off on IPR, please.
So the IPR has taxed us. So most integrated performance reports sit within provider organisations, and it's reasonably clear, although provider organisations do often have a debate around whether the integrated performance report meets the needs of the organisation and is it timely enough, and does it lead people to ask the questions that need to be asked. Our IPR is a bit of a hybrid document at the moment between that of a strategic commissioner and a strategic convener, and that of a detailed delivery IPR. So we are going to review this. So just like with QPOC, the Quality Programmes of Care Committee and the System Improvement Quality Committee, we don't want any duplication. The same for the IPRs between our organisations and the ICB. So during the course of the next couple of months, we're going to do a root and branch review of it and align it with the assessment frame, the oversight framework that an integrated care board will have, which I think will segue a little bit into our integrated care partnership arrangements, so that as a board we know that we're going in the right place for both of those things. So it's a couple of months.
No, that's fine. And one of the challenges, Kate, I'd like you to reflect on is bearing in mind when I did my chair's update, I talked about the desire to want to have a group of people with lived experience reviewing Part 1 board papers, of which our IPR is always part of that. I would love to be able to hear when they read the IPR, I get it. Yeah. Because it's very much, I think, in our speak still, and our graphs and charts and whatever else. And therefore, I think that's not to underplay the importance of that, but that extra mile needs to be able to convert it into simplistic understanding for 500,000 people in Cornwall and the Isles of Scilly who get the implications of this. So
we need to be really careful we don't train our lived experience committee how to speak our language and understand our stuff. We just need to make sure that they're just saying to us it still doesn't make sense.
And that's the point. And that's what I'm trying to get at. Yeah. And they will be the stone in our shoe.
Absolutely.
To make sure I don't get it. Did you want to add something?
It was just to say in relation to that review, it would be really nice, just picking up on Stuart's point, to have a broader range of primary care and voluntary sector services in a refreshed IPR. Be really happy to work.
Because one of the issues we've got, general practice might be feeling vulnerable, but our voluntary sector is also feeling the loss of funding from certain places, and we just need to make sure that we've got a sustainable, viable. I keep wanting to say third sector, but having been corrected that they're the first sector. I'll come back to voluntary sector. We've got a very bouncy voluntary sector landscape, and we need to keep it.
I'm sensitive with the word voluntary sector. That's the reason why everyone thinks it's just volunteers.
Yeah, no, it's not though, is it?
It's
so
not.
Which is why I said third, but then third is denigrating the work of
community sector.
Yes, community sector.
Is where we landed before. Cool, right, so the structure of where I said we would go. So we're going to turn first of all to Patrick on workforce, and possibly you can shine a light on where we're going with some of this.
Thanks, Chair. So as part of the IPR update, we want to be putting in place a workforce dashboard that sits in the monthly IPR and have a regular regime of reporting on that. And the work that's in development in the first iteration is geared to the 24-25 operational plan that we've just signed off. So the core metrics that I anticipate being in there that we would be reporting on routinely at system level will be whole time equivalent levels against the OP plan that we've committed to, agency usage against plan, and probably two other core areas, one around retention, one around absence levels. And over time, we'll add to the sophistication of that reporting. But in terms of core reporting that this board would need to know that it's on top of progress against plan, those would be the core metrics. So I'm hoping that in the June reports, we would have and this is subject to the technicalities of month 1 financial reporting, but we would know where we are on April, and month by month we'll be able to see that. The part that we need to work through, and we'll need to take this through SEG, I think, is to make sure that this ties in with the timings of the Trust's own reporting and data validation and so on. But that's the intent, is to bring that dashboard on a regular basis through Workforce Committee and into here.
So again, Sanj isn't here, so I'll sort of put some of his words to you, and Tom and I have spoken about this too. So there's something about being cited enough, given that we've got balanced budget, we've got the ability to have certain full-time equivalents we agree will be part of that budget, but we've got a cap on it. But we've talked about a salary bill cap rather than a full-time equivalent. There's something for me about how, this was Sanj's observation to me, is how we make sure that we're not committing to whole-time equivalents, assuming that we're making our SIP improvements, etc. only to find out our SIPs don't perform, and then we've made the investment in people. So, and then you can't unpack that quickly. So there's something about the information you need to have that goes through the Workforce Committee, because as much as I'll be asking Sanj for assurance on some of this, Tanya, you need to make sure that we're in control of the balance from a workforce perspective with the agency and whatever else. And that data needs to help inform that, you and the board.
Yeah, absolutely. And that will come through Workforce Committee's Patrick.
Very happy with that. And it will triangulate with the finance data as well as part of the IPR. I think that's the bit that we need to.
It's about the timing of the investment is the point that I think Sanj wanted me to raise with you. Yeah. Anything else on workforce? No? Okay, so we're going to move to finance. Again, feel free under this heading to raise anything you want, but we do have an agenda item on it. So at this juncture, what would you like to add?
Briefly rehearsed, all organisations submitted balanced positions for the year end as we'd anticipated, and obviously the benefit we're seeing from that is the 1.6 million contribution to capital in our 24/5 plan, which is part of that, and our 115 million historical debts being written off. So it was just to highlight those things which are important as far as 24/5 and ongoing is concerned, and that would be.
Please, minute the debt being written off, that'd be.
And celebrate.
Yeah, great.
Has any capital projects come as a result of this good news of 3 years of write-off?
No specific ones, but we're still anticipating further incentives for organisations that are in balance. Yeah.
And then we'd want to look at how we would spend the capital so that strategically we finish off some of the things we've started, embed that, and then move forward to next year with continued community service development.
Thank you. At this point, any questions for Simon? David?
I think it's really exciting, isn't it, the prospect of some additional capital. And I just wondered what the process will be to ensure that as a board we're able to prioritise. Today we've been very good at taking opportunities for defined pots of money to do A, B or C. But is this capital going to come with strings? And even if it does, how could we make sure we invest in some of the underserved areas?
Yeah, completely. Yeah, does it come with strings? Don't know. So, because in fact, the regional finance director was going to a meeting yesterday to talk about incentives and how they would be designed. But in terms of the process, we'd be handling that locally in the usual way through SEG and through board to make sure there's a fair distribution.
So I'd hope that the permissive nature that we've had around quite a lot of the allocations we've been given recently continues. So that we're a system that, my personal view is, we should be backed. We're doing what we said we're going to do. We are delivering year on year. So as money comes down, I think I'd want to be in that, self-autonomy space that we know best where to put our money for optimal impact. So that is certainly what Simon and I will be saying as part of any discussions.
Yeah, because it would certainly be really helpful for things like integrated neighbourhood teams, co-located community hubs, those sorts of things, that we could actually invest in areas that are non-secondary, including my own services.
But Debbie's adequately covered it, which was, I think we should be thinking broader than our.
So in terms of timing, clearly we've used today's agenda item, when we were planning 4 weeks ago, to be focused on the operating budget and the operating plan. Now that we're hopefully, I won't say past it, but we've worked together to sort that, we need to look at the forward agenda going forward. Just looking at that now, for July at the moment is an estates strategy update, because we've actually not had one as an update. And I'm just wondering whether, is that an applicable moment to broaden it such that it's a capital one, because we'll have finished Q1 by the time we get to that point. We'll be in grave danger of not having anything.
So probably, I mean, and I think, Simon, we need to be clear around the additional investment we're making into general practice, lease arrangements as we're seeing new practices emerging or extensions to previous practices. So we are already agreeing to future investments for square footage increases in general practice. So I think we need to bring all of that so we've got good visibility of all of it rather than just slices of our capital plan.
So the reason why I raise it in terms of trying to plan it in, Katie, is that, and I really understand this, at certain times of the year we're consumed by budget, get that sorted, operating plan, quality, I get that. And some of the system feedback that we've had, and I've had as part of my appraisal process, is that we're in grave danger of squeezing out other things like the estates plan, a digital plan, our climate plan, and other types of things like that. So I think now we're just past this window. We might use the next quarter to think about some of those other broader strategies and make sure we embed them in.
Because I don't want us to give false expectations, because one of the things we have to remember is the accountancy rules changed. I know it's a capital now, isn't it? Not leasing of estate. Estate costs us money, so we need to be as estate light as we can be, because of the implications that comes with it. So, and when we bring the plan back, we'll have taken it through the system executive group, but we will have also engaged each of our integrated care areas around how we build that strategy, and that will of course involve general practice.
Okay. So. Thank you. So I'm going to give you just a bit more of a heads up. But normally, when we get to the end of this and we look at the forward plan, I sort of say, let the chief executive take it away and have a think about it. I think this time I'd like everybody's insight as to what should be on the next 3 months worth of things, because there are certain things that don't always get on there that are more broader. And Rachel, I'm thinking some of the times, Director of Public Health, there might be things that you sort of say, when's that coming in? And planning that and working towards it and that kind of thing. So I just think plotting out the next 4 or 5 months forward planning, I think now would be a good time to think about that.
So we haven't got a development day, have we?
I'm going to raise that.
Yeah, because this is for me the meat of a development day discussion where we've got time and space to throw a few things round between us rather than just looking at paper.
So under the risk item, that very item is going to come up.
Okay.
So if we can agree a date then, that will come before the discussion of forward plan.
Yeah.
Then we can roll it out. And if we can't nail it now, I'm just setting the scene now. I think there are other things that we need to talk about as an integrated system.
Yeah.
Okay. Okay, so that's finance. You happy with that?
Yeah, very good. Thank you.
Susan and Chris, is there anything on quality on the IPR that you would like to focus on other than when we talk about operating plan?
I think one of the areas that we bearing in mind the IPR is at our position at the end of March. So we're looking back, not looking forward. One of the areas that we picked up through the quality committees was duty of candour, and I know that our providers are doing their own, I won't say deep dive because it's an overused word, around duty of candour. It's an important part of our obligations. It's a legal requirement. So we know that we've been off target where we need to be. There's a piece within the quality report within the IPR that explains duty of candour, what it is, and where we're expected to be. And I would like to thank both of the quality committees on our providers for taking this on. And we've got oversight from both chairs on how we recover our position on duty of candour.
Good. Any other questions on quality? We'll pick them up under. I think I just need a little better quality conversation for the operating plan, and that in a second. Okay, colleagues, let's move on. Thank you so much. So let's move on to the risk scorecard. So, Molly, we're in your hands.
Yeah, sorry. Were you not going to pick up performance in the IPR? Because there was a point I wanted to raise.
Yeah, no, go for it. Yeah.
Sorry to interrupt. So I don't know whether Susan wants to talk to that section or whether I should just ask my question, but there's...
You ask it. I was going to try and cover everything in the operating plan, but feel free to pick it up now.
Well, so I wanted to draw the link. So if I go to pack page 90, there's really helpful update in terms of the work that we've all been undertaking as a system on the no criteria to reside. And I know it sounds complex because we always look at what are provider actions, so that's somebody who's ready, but we've still got a bit of work to do, and what needs to be coordinated in terms of onward care, and we call those ITOC actions. But you can see that we set ourselves the initial target for achievement of no more than 80 people in RCHT, no more than 80 in RCHT and 65 in CFT. And Susan, that if you look at it from an ITOC perspective, that was achieved. And that's I just think sometimes we don't actually say we set ourselves ambitions. And today, well, yesterday's report, but yesterday there were 50 people in RCHT with no criteria to reside with an ITOC action. There's 69 in total, and in CFT there was 61 and 76 in total. So it really is a moment for us, because we were continually saying, weren't we, collectively, our flow issues were holding us back. And I also wanted to give a shout out to the ICB and the council for mental health. So although we've not achieved the mental health ambition of no more than 10 people, and we've got 17 people in mental health beds currently with no criteria to reside, that's a significant improvement from the 27 that I reported at the last board. So the actions that were agreed at the last board, Chair, have really started to deliver, and we are seeing a commensurate reduction in out-of-area placements. So we're not anywhere near there yet. The one point I did want to raise, Susan, is that I know what you mean by this, but the very last sentence on pack page 90 says, the ambition of this sprint is to have no more than 10 people in a CFT mental health bed by the 31st of March. That's a nice ambition, but I think you mean no more than 10 people delayed. Yeah.
Delayed.
Wouldn't it?
That's a great target.
Yeah.
Very excited writing it.
Yeah. But the challenge that I continue to face in both my community services and in mental health services, and I know this also applies to UHP and to RCHT, is also the lack of housing.
Yeah.
And we have if you start looking at who's delayed now, the very, very long length of stays are often to do with lack of housing. And I therefore really welcomed Ali's reference in her report on the extra care housing business case and the strategy for care homes, because this is absolutely needed to drive out those very long lengths of stay. Thank you, Chair.
Okay, and while we're on that, Ali, that for me is an example in terms of how we might, when we're thinking about the forward plan, we might want to have a discussion around that kind of thing, so everyone is cited it, because it's in the report, but to actually make everyone aware, a bit like Mary raised some wider issues. I think that's the kind of thing I'm trying to encourage over the next 3 or 4 months.
And it's the segue then into the ICP, isn't it? Because the ICP space is where collectively as a broad public sector, we can only do the work together that space can do. So this board needs to feed those discussions. Can I just pick up the no criteria to reside though? Because we are really good, aren't we, at telling ourselves we need to do better and challenging each other to do more. Well, the position that I've got yesterday's no criteria to reside up, I don't know we've ever been in that place before. We talk about whether the winter plans worked or not. It has, because the services that were put in place have yielded this. I suppose what I'd like is almost to take a picture of this. Goes back to Steve's point. We can't lose it. This is our absolute proof that what we've been doing works across all aspects of the work that we do together, not just people around this table. So we need to put it somewhere, and don't forget. Debbie.
Never tire of hearing that. So, no.
So I know that in talking numbers, you're not forgetting the impact on individuals, but I think it's always worth coming back to the impact on the number of people who are not spending long lengths of stay where they're not wanting to be, and not back at home and not getting on with their lives is huge. And I think when we think about those reduction in numbers, we need to think about the impact on the individual people and patients who we're seeing better looked after. So thank you.
Susan and Chris, anything else you'd like to add on performance? I've got one question in a second, but anything else you'd like to add? No.
I would like to point out is we've got, as you know, we're in the System Oversight Framework, we're in segment 3. That review takes place over April, May by NHS England to review our position. The only other point I wanted to make, because we've talked about primary care a little bit, and I know that in the IPR we are sort of governed by the metrics that we have to measure. The one for primary care is the 90% appointments within 14 days. And primary care ended the year at 88.25%. So I just wanted to say thank you. Knowing how much pressure primary care has been under, it's a great statistic and it's great for our population.
Is there anything you want to add?
No.
Okay, thank you. So I've got just a couple of questions. I'm really happy that we stay on this section on performance, because there's a couple of performance questions that I would have dealt with later on, but I'll deal with it now. Can I try and understand, for everyone's benefit, not just my own, can you just clarify the clinical reference group, where it fits in, who's in it, what's happened to what we call CPAG, Clinical Prioritisation Advisory Group? Is that different? Have we ditched that? I just think it would be helpful to have clarity on what are they, what's their relationship to SEG, and everyone is 100% clear on what they do.
So the clinical reference group, I think, are making sure are a provider space, I think, to sort of guide, steer, give recommendations on how, for example, diabetes should be managed as a system. So it's, first of all, it's a system-wide lens. It's ensuring it's not just clinicians are in the clinical reference group, but the appropriate representation. And I often describe them as saying they are there. If you take diabetes, they're there to take a prevention lens, a personalisation lens, a place lens. They need to have a population health and an inequalities lens. They need to describe the end-to-end pathway, noting that there's still noting the preventative element and the personalisation element. And then they need to also start to articulate what they want about how their workforce needs to operate as a system. So it's not just the workforce in primary care or in secondary care or a voluntary in the sector. They need to therefore look at the estates and the digital ask. And then as they mature, they need to almost tell us how they need, what sort of service therefore we need to have, and what metrics.
How do we find out who sits on it?
So I think they'll vary from group to group, and some of them are in essence morphed from previous steering groups. So for example, the end of life palliative care alliance will morph into a CRG. There's been a diabetic group that is now established. So they do vary on who's who depending on the historical element. Right. So our priorities to set up, just to finish, are obviously diabetes, respiratory, cardiology, and end of life and frailty. They're the key ones we want to make sure we've got in place to have clarity.
Popping in Kate, I think Kate, if you could help us, I'm trying to understand how many there are.
Yeah.
How would we know who's on them, just for transparency, and how? Is there still a relationship between that and the clinical prioritisation group, or has that gone? So I'm just trying to understand transparency.
We still have a CPAG, and CPAG's not met for a little while. And it has to be said, we have become all goal focused. So when we watch young children playing football, they all chase the ball. That's what we've been doing. It's called the plan. So we need to go back into our shape going forward. So CPAG will sit, and it's made up of our senior clinical leaders and advisors to the system executive group around what we should and shouldn't be doing from one place to another. We then remember we have 6 programme of care boards, which we're going to have programme of care managers that will be part of our phase 2 restructuring, and we'll be going through the process of putting those people in place. Once we've got those people and they've got their teams in place, they will relate to the transformation support hub that Tracy will manage on behalf of the Integrated Care Board, because that's where all the programme support to the work that those programme of care boards will do. The CRGs are the detailed pieces of work that go into each programme of care board, and the ones that Chris has described will probably all go into the long-term conditions programme of care board. Adrian Flynn has already set up the mental health, learning disability and autism programme board. We need to get some programme support around him so that he's able to be supporting the work that he's doing. But if we go back to Seek last week when we talked about diabetes and the community hub event that I attended, when Diabetes UK were there and told us that we've got some of the largest numbers of diabetes-associated amputations in the country. That for me becomes a CRG question. So diabetic CRG, please can you help us engage with Diabetes UK, because we'd like to know why that's happening and what we can do about it. That will then go through the structure I've described for prioritised decision making if money is required.
So is it a fair ask just to say, could somebody just write down
we'll
what
bring
those
a
are,
paper.
who the chair of it is or something like that? Just a bit of wiring?
Yeah, and they will be what they need to be. So there won't be standing armies, there'll be task and finish groups.
As our part of our new model, what I'm trying to help people with here is sometimes in a vacuum people think, I get it, and they don't quite get it. With your vision. So there's something about you articulating so that we all get it, because it's going to be...
I'll take that as an action.
Okay, all right. Thank you very much. Emma, on the screen.
Yeah, thank you, John. Just adding to that, I'm really grateful you brought that up. I know it's something we've spoken with Chris and others about, and it's very much in its formative stages again, but it would be immensely helpful, both for me personally in my role and more broadly for general practice, to have that wiring diagram, please, because there are certain things that may not logically fit within those clinical reference groups that we are challenged by general practice around when pathways change, and there are discussions that need to be had that used to be had in old speak with referral management system groups and those kinds of things that don't seem to be happening. And I think that colleagues across the integrated care system, so colleagues in CFT in particular who we've spoken with, are equally concerned to make sure that that happens, because there are some things that are really important that have been parked for a while. So that's really helpful.
Thank you very much. Okay.
Can I invite everybody to be noisy? So if because we're starting new ways of working, aren't we, and trying to ingrain them in a codification of how we'll work going forward. So if things aren't working, can we raise really quickly, this isn't working, can we look at it, rather than get into a disaster further down the line?
No, hear that, Kate, in the nicest possible way. You can imagine that I have been quite noisy, so yeah, we'll continue happily to do that. I don't want to cause issues for people, appreciating that patience is needed, but we have been raising this for quite a number of months now, so it'd be good to just to understand what's occurring.
So Susan and Chris and Kate, final question from me. Bearing in mind we are a statutory body and we have some constitutional standards that we have to achieve, out of this IPR performance, would you say we were achieving our constitutional standards, or will you say there are still some challenges?
There's still some challenges.
And how would we recognise those?
So the pack is very clear I'm saying the pack is clear. The pack's clear to me because I spend a lot of time with it, but take your points that we do need some plain English, a plain English approach to this. And what we've tried to do is make it a combination of the statistical process charts, SPC charts, which some people love, and a narrative that other people will gain more information from. So we know that our constitutional standards, for example, around things like 4-hour standard, we're not hitting it. However, we are improving all along. And I think what the narrative tries to explain without creating a document that's war and peace is our journey towards that. I think the at a glance, we've put some at a glance charts in there to give us an idea of where we're at with those constitutional targets. Does that answer your question?
It does. I think what because I'm now ingrained in the NHS, I'm getting it, but there are certain colleagues who actually ask me the question, are we achieving them? And by definition, if they've read the papers, which I assume they have, it means that it's not as clear. So maybe next month, even while we're waiting,
Yeah.
we could just be quite clear. These are the constitutional standards that we've maybe got more work to be done on, and there it's the transparency and recognition that we are on these and not on the others.
So I think going forward, it's in the pack. We have to demonstrate as a board IPR where we're at on the system oversight framework.
Right,
So that's really important. We then have to give an update on our constitutional targets, and then for next year, the next IPR will be focusing on our 24-25 priorities that we've agreed as a system. And as Kate said at the start, the IPRs that sit within our provider trusts are for them. We need to bring it up to be really clear about those constitutional targets that we have to hit as a system. So that's our elective, that's our UEC. And as I've said, some of the constitutional targets that we have for primary care are really limited. So we are going to have to think about how we represent without creating a tome of papers.
Page 3 of the pack. I don't know what page it is in for people that've got it online. But it basically looks at our strategic oversight framework.
Yes.
So if you look at the soft ranking, the monthly change from February 24 to March 24, it'd be great if we could do the annual change. We are more compliant green, less uncompliant red, and more compliant amber. So we are shifting our performance towards improvement. And one of the is it anecdotes? Is it unofficial feedback that we've had is that we may be being asked, given what we need to get to soft 2 rather than what we need to do to avoid soft 4. So that should be around the confidence within which we're going into the next year. Our providers have done an amazing job in difficult circumstances in every part of our system to keep us moving towards improvement, which is just the best thing for our people. Page 78.
So I'll leave this thought, Susan, then. As we're statutory board members, each of us, the point being made that I'm trying to be helpful here with is, can we have real clarity as to the areas of constitutional standards that we are achieving and the ones that we're not?
Yep.
And then how do we focus our attention on the ones that we're not and elevate them to more of our debate? And I think just that little helping hand would help us immensely.
Yep. So we can have a front sheet, which is almost like a heat chart that will describe it. But it is, I would just like to say, Chair, if I can, it is in the narrative, because what we've done is disaggregated areas where we know that we're not hitting the target. So if you look at diagnostics, for example, there are a number of areas within that are absolutely hitting the target. What we've done is disaggregated to understand where we're not hitting and what the actions are, and that is in the narrative. But I appreciate we can provide something that's at a glance.
And I'm going to say it just one more time. I'm going to try and represent 500,000 people out there who don't understand our facts, to see how they would quickly get it. And I think that's the challenge.
Yes, absolutely. And the IPR is like the Forth Bridge, I have to say, painting.
No. And it's immensely complicated. My hat off to people who actually write it in that. But
thank you. Just a couple of observations. I thought the narrative was helpful, and I did read the papers, so thank you, Susan. And I just thought, because we're having the mental health and learning disability deep dive, I just wanted to pull out, having looked at those soft measures for some of the mental health standards, the LD health checks and the access to IAPT, which is the talking therapies. We had the vignette as well, I think, that was mentioning those. I note that there's an action plan against that, but they have been both targets that have been consistently below and in the lowest quartile. So I just wanted to raise that as noted the work that's going on, but it is a challenge, and we should obviously be aware of that one. And then the second one, which is an issue I raise, I think, sort of at most performance items as well at the board, is the CBD achievement of hypertension management in primary care. It is somewhat below, consistently again below. I know that there's work going on to raise public awareness and opportunities for blood pressure management, but I do see that as something that we're not really paying attention to very much, and I'd like to raise it again as an area, because it has such an important impact on health inequalities, and is an opportunity that I feel that we're not sort of taking advantage of.
And then I'll bring in Debbie.
So I couldn't agree more. So one of the discussions I think we need to have is around what we commission primary care and general practice to do. Is it inputs or is it outputs? And that might help with some of the stabilisation of general practice as well. So it's a conversation we need to start having around how we, I don't know, flex our expectations around what we're asking colleagues to do. But we do know that if we sort some of the root problems of broader health around prevention and anticipatory care, then we're much likely to get better outcomes for our population. So you make a great point.
Thank you. And I think that opportunities around prevention for some of that cardiovascular management is something that I know Chris in the CRG wants to be focusing on, linking with diabetes as well.
Conscious of time now, so Debbie and then Martin.
So absolutely pick up Rachel's point, and I think that in terms of making the IPR understandable, I wonder whether an alternative way to frame it is to actually get some service users with lived experience to help us with easy read. Because certainly I've worked in other organisations where
I like that, yeah.
where you keep the IPR as is in the corporate speak, so that everybody knows where they are and they can rely upon it in performance management meetings externally. But then we use the easy read experience, which I think sits in the council in Cornwall, doesn't it? Yeah, to actually craft then what would have meaning to them and how would they suggest that we present it.
I think that lived experience group we were talking about earlier on would certainly help on that. Martin?
Yeah, I just wanted to follow up on the primary prevention point, really. And, you know, I was struck in the report, and Stuart mentioned it earlier, you know, the number of primary care or GP appointments, I think, was 375,000 in a month, you know, more than half the population. And just how we are helping with that, you know, in terms of signposting, direct access to other services, things like the pharmacy first, which at some stage I think we need to bring back and understand how that is working. All these things we need to support to somehow reduce that burden on primary care to enable, I think, more time for primary prevention, the blood pressure checks, whatever it might be. So I'd welcome at some stage, you know, some more views on how that work's going.
I think if you could, when we get to the forward plan, I know Drew's not on the call, but I think maybe getting Drew from a pharmacy perspective to be in the room when the team do a pharmacy update, so that we might have a view, but he might go, I've got a different one, would actually be helpful.
And it would be great if we could talk about sustainable alternatives, because I think what happens sometimes is it is there, but it's not there all the time, so people stop using it. So we should have that as our word going forward. Everything we do is sustainable and ever present.
Cool. Okay. Thank you. So I'm going to move us on now, because we're actually now eating into our time. So we're on the risk scorecard. If you could be compact and busy, I'll be grateful. But we did say in here we would talk about the away day as well. So do the score.
So the paper in front of you today is to give an update on the work that was undertaken in the prior financial year on risk appetite and the steps being taken forward to progress and inform our 24-25 position. So most of the board members will remember a session we had on the 10th of August last year, where we looked at the risk appetite and we also had some draft objectives for our risk strategy. And so the update today is to inform board members that we'll have an away day in June to receive the output of that work, which is also associated quite closely with the refresh of our risk position. But it's also worth flagging that there's a lot of work that's been going on behind the scenes. The board committees have been doing thematic analysis of risk. Finance Performance Commissioning Committee has been doing deep dives as well and looking at performance risk assurance, and all that work we brought together to inform the output. So as John said, we need to obviously firm up the date for the development day. So apologies at this stage, I'm not able to confirm what that is, but we're going to do that quite. And just a couple other things to highlight that at the time of writing this report, it wasn't quite clear when we would start having our risk and compliance. I'm pleased to report that it will start on the 13th of May. It'll be chaired by the Chief Executive, and the output of that meeting will be taken to a further NEMS and an execs meeting on the 23rd of May to inform the iteration of the document. So I'll pause there, Chair, if there's any questions.
Any questions? Come on. Happy to note that. And you're going to get a date for this group to have the away day. Lovely. Thank you very much. Are we happy with that?
Thank you, Molly.
Thank you, Molly. Okay. So We've now got 25 minutes on the operating plan and budget. So, Kate, how would you like us to structure the next 25 minutes?
So if
Everybody's read the papers.
yeah, so if we could just ask, I think if we could ask Susan and Chris to talk through the elements of our plan that are new and are working with the evidence that we've got. Simon, maybe to talk through some of the high-level risks and opportunities, and then our provider colleagues who have been part of developing the plan. I'm sorry, I looked at you as a provider, that's Debbie, but from a sector feedback, how it's felt to get to this point. I think would be really
helpful. So who's going to go first? Susan, Chris?
Yeah.
Okay. So thank you, Chair. Our operational plan now, we've talked a lot about this, but it's bringing it together. And the first thing I would like to say is the slides that you've got in your pack are an appendix and was an example of some of the work that we are doing. And we thought it was really helpful to bring those here because those were the slides that the national team saw by Janine Glazier and colleagues, and start to illustrate the direction in which we want to travel as a system to create the best outcomes for our population. So the operating plan, as we know, is about the operational recovery against our national standards. It's improving value, which I won't go near because that's Simon's, and the transforming care. I think in terms of the national standards, Chair, we've talked quite a bit about where we need to recover. We know where that recovery is around our urgent and emergency care, our planned care. So it's people who essentially being delayed for treatment, whether it's through the ED department, that route in, or on a waiting list waiting for a treatment. We also have recovery that we need to do around mental health, and I'm not going to go into detail because we've got the mental health deep dive a little bit later. It's also about how we locally have recognised the issues that we have, and I think we've spent quite a lot of time during our boards talking about some of the challenges that we have across Cornwall and the Isles of Scilly, not least of all our mortality and our morbidity. So the amount of people that die and the amount of people that suffer harm as a result of either not being treated or being treated too late. So all of the clinical transformation that we're looking at is around how we do least harm and give the best outcomes. So as the board will know, we talked very much, and we are still working through the amount of projects that we had, and at one point we had 17 different work streams. So we are pulling that down into a much more refined work stream of around 6 clinical priorities, and we talked to NHS England about this, and they agreed, both at the national team that came to talk to us and regional, that whilst Cornwall had some great ambitions, Cornwall and the Isles of Scilly, sometimes it was just too much and we needed to distill that down. So we've done that, and we've worked that through the system executive group and various other meetings that we've had. So we've agreed that frailty particularly and end of life are 2 of our big priorities going into from last year going into next year. We also presented our clinical strategy to board some months ago to say that we would also prioritise diabetes, cardiology and respiratory, but that's not to the exclusion of everything else. We know that we've got a lot of work to do around cancer. We know we've got a lot of work to do around children and young people and mental health. But this is where we said that we would put a focus on for the coming year, and where we will be measuring ourselves against as we go through. So enable to support the work, particularly around frailty and end of life, we decided that and we agreed as a system that we would concentrate efforts on discharge to assess. Mary very briefly touched on it, and some of the impacts when we don't get that right, discharge to assess, is that people end up in the wrong place, and as a result it can be detrimental to their overall outcomes. Neil also highlighted that when we get people out of hospital, whether that's RCHT or the community, quickly they have better outcomes. They get back to their lives and regain some of that independence. We also agreed that mental health, we needed to concentrate a work stream around mental health to enhance mental health pathways, but also to make it much easier to access and much quicker. Debbie's already talked about some of the difficulties that we have in mental health around people who are delayed, which then mean we have to find beds out of area for other people who we can't put into our own local beds. That's not a great experience, and we want to repatriate and not actually, we have a target for 0 out of our area placements by the end of the year. Primary care, we've talked quite a bit about primary care today and the role of the primary care hubs. So how do we get people into a service where we deem it as, or we've agreed that it's low acuity, so people who aren't acutely unwell, but high volumes, which at the moment RCHT have had to suck up, particularly out of hours, and that's the area that we really do need to concentrate on, which brings me to 24/7. Now, we know that 24/7 services are expensive, Chair, so we have to be really clear about where we get best value for money and best return on those investments. So some of that work will be around our frailty SDEX, so that's same-day emergency care, and that's seen as people who can go to a service and be turned around very quickly, and if they can't be turned around and need a short stay, some of those short stay beds should be in the community, and those are our community access and treatment units, our CATUs, and we need to set some really clear objectives around the use of those beds, and I hate to say key performance indicators because it's very it's very NHS, but it's really important because those key performance indicators are there to protect people and have the bottom line of creating a safe environment. So all of the work that we're doing around transformation this year will be to try and allow RCHT to regain what they need to do as an acute trust. So people who need co-location against intensive care and higher care, as well as having surgery, is really important. And a lot of people that go in, and in fact, if you'll allow me, indulge me for a moment, I was on call this weekend, and as Steve's pointed out, some of the progress we've made, a lot of the progress we've made is fantastic. However, we know that our weak areas still remain around after 5 o'clock and at weekends. We had a bank holiday weekend, and what we saw this weekend were people who maybe are losing confidence, who are at end of life and are making that last sort of minute phone call. Few services around at the weekend and they're having to go into the acute trust. People who are in that frailty spectrum are also at bank holidays, are not getting the services they need that they would get during the week. So we are very clear about where we need to focus our attentions, and that will have that positive impact on our category 2 mean time for our ambulances, because when we look at our cat 2 mean time, if again, I'm using the word disaggregate, if you disaggregate that over maybe a 2 to 3 hour period, you can see we fare really well during in hours. It's out of hours where we lose some of our efficiencies and our gains. So we know we're in a better position to know where we need to address some of our 24-hour services. But in terms of a direction of travel, I think we've all agreed that going for frailty and end of life is where we need to be. And there will be positive impacts for cardiology, respiratory and diabetes, because some of those pathways we would call low risk pathways, and we can take those through our same day emergency care. And certainly talking to Tamsin and Debbie, that's something that we would really like to explore. And then what we would start to see across that spine of Cornwall are areas of expertise that look after our elderly populations. And if we start to wrap research and development around it, it makes it a really exciting perspective that we can start to lead the way in Cornwall and the Isles of Scilly. So I'm going to take a breath and pass over to Chris. Sorry.
Well done, you. Yeah, don't Simon. Like I say, I don't think I've got much to add. I think you articulated that really well. Thank you, Susan. Well, if I take a sort of slightly patient-centred approach to this, because I think sometimes you could. So if you look at our population, we've got a super aging population. We've got coastal deprived areas, and actually from a patient-centric point of view, what's best for a patient and their families, frailty and end of life are overwhelmingly these big ticket items that we know if we address these and deal with frailty where at all possible at home in the community, it is better for the patient and their families. It also is better for the system because we know it is a more cost-effective way of delivering better quality care. It takes the pressure off the acute trust. So fundamentally, that's core to that operating plan. It's the right thing to do for patients. I think that was really emphasised at the GP collaborative workshop last week that Stuart ran. And it's fair to say a priority that the GPs want is to address frailty. So it's something that resonates both within primary care, that they see this as a huge part of their workload, that they need to have a different way of looking things and to support. And of course, end of life dovetails into that as well. Again, where at all possible, you want end of life to be in your community and at home where at all possible. Having more of an integrated approach around the community primary care just fits with this operating model, the primary care hubs, the integrated models working more with the community. And if we take sort of the intermediate care strategy, which we talked about last year, where there's 4 key pillars, that pillar of prevention in terms of risk stratification, identifying those patients who are frail, that becomes a really important way of having effective care. So that pillar 1, that identifying the patient becomes really important, because then there's lots that we can do with the voluntary sector within primary care to stop people going in and falling into that acute system. And again, as Susan pointed out, it has to have a 24/7 element to this offer. So yeah, that's my key points, but I think Susan covered it.
Thank you well done, Lou. Thank you.
I just wanted to come in briefly. I really support the work that's going on here. I just wanted to raise an idea that might help us going forward. And that when we really get into these discussions, we need to talk about personalisation and predictability. Because actually the circumstances, if you are frail and elderly, or if you are at end of life and you live on your own, and you don't have support, it's much more predictable that you're going to be much more fearful and that you're going to be much more likely to be calling the ambulance and ending up at the hospital door or in SDEC, or not able to die at home because the services can't be around you to support you, whereas people with families, it will be. So I'd just like that individual circumstances to be part of our assessment here, not just a whole system approach, so that people's personal journeys are taken into consideration.
That's that part of that risk stratification of patients to identify those who are more likely to need that input. Yeah.
Thank you, Emma.
Chris and Susan will know this, but other board members may not, that the ICB is hosting a Macmillan-funded end-of-life transformation post, which is really exciting, I think. And we're already working with Natalie. She came to the Hubs celebration event last week to start doing some of that engagement around what people want from end of life, and we're working with her to look at mapping all of the services across that are working with end of life care. So again, I think just going back to where we started at the beginning around joining up services across mental health, we're really starting to look at that for end of life as well, which is really exciting.
And of course Natalie knows this, doesn't she? Because Natalie did work for Health Watch before she took this role. So
okay, thank you, Stuart.
Yeah, I mean, just thanks. I think we all really appreciate the all of that excellent work around, particularly the intermediate care offer. And just to reiterate Chris's point, we had the GP Collaborative Board Away Day, and where we set our priorities for transforming general practice and providing resilience, which will come back to this board with a paper hopefully next month via Paula and team. But one of the 5 priorities was indeed frailty, and we certainly feel that as GPs, we're not great at a lot of things, but I think frailty and end of life is where we can really add value. And again, just to speak to Tan's point, a part of that is some technology that identifies those people tipping into frailty, and then proactively going and having the discussions around personalised care with those patients. Hopefully an example of where we're very much aligned with both the ICB's priorities, and just really a plea to Susan and to Chris to keep engaging with the GP Collaborative Board on this really important piece of work.
Thank you. And just before I bring in Neil, of course, later on in the day at 2 o'clock, we've got Juliet and Trifina on personalised budget update. Just to remind everybody. No.
Thanks, Chair. It's just to say that this particular page that says System Urgent and Emergency Care Pathway Transformation is so different to where we were some time ago, when we're actually outlining urgent and emergency care and we're putting in all the ingredients that are needed throughout as a system. It should allow, as one outcome, not forgetting the patient and the personalised care, each part of the system to be able to identify what's in it for them. And I think you put it that way, Susan, in what's in it for acute is they can get on and do the acute work. What's in it for other parts of the system is more resource, tailored skills and workforce that allow a better experience for people and the staff working out there in the community. This is really welcome. For me, if we wanted to absolutely get everything in that we needed in that one page, I'd like to see voluntary sector mentioned. But other than that, for me, it's a perfect example of where we needed to get to. And if we do this year, I will be absolutely delighted for people in Cornwall, because it's the right thing to do.
Set up beautifully. Thank you so much, Neil. Thank you. Great.
Do you know translational or I was going to say translational research, but using things that you know work well in other places. So we know multidisciplinary teams give the best possible outcomes for people using them, particularly if they are focused on the person rather than the condition. And I think what we're starting to describe for a system is what a system multidisciplinary team looks like. So which organisation is best placed to do certain things? We should be encouraging them to do it, not trying to get them to do things that they're not best placed to do. And if we have that across the whole set of skills and talent we've got in Cornwall, we are most likely to be able to meet most people's needs in a way they wish them to be met. I just think it's really exciting, and yeah.
Thank you very much. So that leaves us with the small item of the budget, Simon. So 7 minutes of enjoying what you and the team have achieved. So over to you.
Thank you. So obviously the first thing to say is thanks to the system and finance colleagues and all the exec teams, because it has been quite a journey. And I will say the roller coaster peaks and troughs haven't been as deep and significant as they were last year. So it feels like we're getting to a much better place. So a big appreciation there. I think it's also helpful in terms of planning context to say that we're one of 3 ICBs in the Southwest who delivered on the May the 2nd an agreed operational plan, including break even. So I think that's a good place to be.
Yes, let's do that. I clap all of us.
Well done, everybody.
So that puts us in a good position to actually get on to position of delivery. And it's worth highlighting the key things I think we are dependent on. So firstly, I go back to the areas described by Susan. So we've got a significant explicit reliance on service change to provide the right care for our population, but also to deliver better value. And within the plan, I'll mention there's a net 5 million requirement, and we're talking about all investments, including that for channel shift, would need to demonstrate amongst all of our system that they're going to deliver a net benefit. So we're providing the right care and it's costing less because it is the right care. So the two things line up very, very neatly. And I think this is the year that we have to deliver it. I'm stating the obvious. And I think everyone agrees that in terms of 25/6, the only way to really manage value and work within the envelope of money we get from national government is to change and drive out that more effective care model. And it does feel genuinely, so I hope colleagues will agree that we're all facing in the same direction this year to drive that value through. We don't want to be spending excessively in escalation areas when we talk about UEC performance. We want to be ensuring patients are in the right place and they're not in the acute sector to the degree that they might be at the moment. So we're all talking the same language, and that feels much better. So I think the transformation programme is absolutely key. I will mention the other areas that are important. So elective recovery is the significant contribution in terms of funding to our patch. So delivery of that will be absolutely vital this year, and deliver the performance we want to on waiting lists will be key. So that will continue, I think, to be a theme in future years in terms of where additional resource comes from the national team. Our highlight CIP, the standard cost improvement programs we work on alongside transformation, will continue to be a major focus. We've got significant expectation in 24-25, and what I will sit alongside that, which we've committed to as part of this plan, is that by the end of May we set out a grip and control plan that both tracks on KPI basis how we're delivering on a month-by-month basis the sort of different programs that deliver improved value, including transformation, and also areas of routine grip and control, such as workforce controls, agency spend. Those are the things that we need to continue to be good at and get better at. And it's a focus for the national team, but clearly it's a focus for us to deliver our in-year position. The areas that I'm particularly interested in terms of the ICB component, I think we touched on it before. Susan touched upon the out-of-area placements for mental health. That's something we clearly want to minimise and ensure we can care appropriately in the local system. We continue to work with primary care on prescribing. That it remains a risk nationally in terms of the level of growth, and everyone will hear about the restrictions and limitations on access to some drugs that everyone is challenged with. So we have to focus on that, and again, that's something that needs to be tracked. And CHC continues to be a focus, working with the local authority to ensure that we manage spend in those areas and people are being cared for appropriately, but that we're reviewing on a regular basis to ensure that we're not growing our spend beyond our plan. And that will be a significant challenge this year and something that we will continue to track. So in addition to that, I will also say that I think the pluses from being where we are is there is national discussion about there being various different incentives for us to continue to change and improve our services. So it'd be good to be able to focus on that. And I'll also add, we've also described, and I think we're all committed to, that we establish a planning cycle for 25-6 that provides a clear starting plan by the end of September this year. And whilst operationally we often get distracted and pulled into the day-to-day pieces of work that are critical, we have to focus heavily on the long-term answer. And by pulling our planning timeline back, that will help. It'll also align more with the local authorities' processes as well. So I think that would be a plus. So in summary, we've got, in terms of money, we've got to a break-even position. There is a lot of risk, so I think we need to highlight that. But tracking and pursuing mitigations will be a vital part of this year. So I'll park it there and open up to colleagues.
Any questions? Heavily trailed this, huge amount of work, other than saying this has been a real team effort. And if I could just reach out to Steve and Mary on the call, and thank you and your board. And Debbie, if you could also pass on the thanks to Margaret and to your board and to everybody who's been part of this. I think it's been testament to the collaborative nature to have got to that point where only one of three in the Southwest have actually got together and sorted this so amicably, and not without its challenges. Okay, so a couple of things that flow out of that from me, and Molly, this is as much for you to minute as well. In terms of the flow from September, I'm going to suggest that we formalise now that we do not have an August board meeting from the ICB. Does anybody feel we should be having an August board meeting now, shout? Because if not, we're going to stand it down. I can't imagine too many people go, no, I must actually have an August board meeting. So we're going to stand that down. How does that change what you need to agree then for September? Do you need then something nailed in July that makes it clear from September what the journey is going to be? Or are you coming to the September meeting telling us what it's going to be? What's the journey between July and September?
From my perspective, we need to be in a position where we bring a proposal to September meeting. And I wouldn't want to bring it forward because there needs to be a lot of work done to make sure we get to a position that's reasonable.
I'm trying to understand, is it a process that you're bringing in September, or are you bringing a first draft budget? I'm just trying to manage expectations.
Draft plan.
Yeah.
So operational
with numbers
and money, yeah.
Oh, okay, cool. So if we could just minute that,
I continue to be optimistic.
That would be really helpful. If that's the case, could I make a suggestion that in July you just show us the process that you're going through, such that we can then help you manage the summer, such that September is more successful? That's where I was trying to go with it. Does that work?
Without completely shooting myself in the foot, I would suggest we bring process to June, because we need to set out the timeline of work as
Everyone's
quickly as
getting very
possible.
excited now.
So, and we've been talking about it with colleagues.
Okay, well, let's aim for June, and if we have to, we'll default back. Is that okay with Debbie? You okay with that? Or do you want?
I think we have to.
Well, I think we have to, but I'm going to need Simon to work really closely with Adi on it.
And it's the process, isn't it?
Just the process this side of the summer.
Yeah.
Does that work for you?
I thought it's a very ambitious timeline, and that there would need to be significant executive engagement, not just from a CFO perspective. And I know that's not what you're indicating, Simon. And I just wonder whether July might be the right time for an ICB summary. And Kate, I'm sure a SEG perspective would be May and June where that work would progress. So it wouldn't be a case of the work not progressing.
I suggest this then. On June, just give us an update. Yeah?
A work in progress.
A work in progress.
Timeline update, which I think would be...
July, really it should be here is the process. And then we work to September. Some early numbers. Does that sound like a collective plan? Right.
I'll just add, it needs to go to committees, obviously, within each organisation, finance committees respectively, endorsing the direction of travel before it comes to the board in July.
Yep, we can do that. But I'm also very keen that it's all sectors of our delivery network, not just the statutory secondary care sector. So we just need to be really clear that moving forward, that we're thinking ahead as to where service development will go for next year.
Okay, sounds like a plan. Let's leave that there then. Simon, thank you to you and your team. Thank you all colleagues for all of that. So we'll move across to Nick. Take us through, please, on the first inaugural Joint System Quality Improvement Committee. Over to you.
Yeah, thank you, Chair. Thank you for the opportunity to comment on the first System and Improvement Quality Committee. I'm going to give a brief update and welcome feedback and input from other colleagues that was there. I would want to say that this is a groundbreaking committee, as been said already, national first, a huge amount of work in the background to get this over the line. So thanks to the chief executive officers and current quality chairs. My job was relatively easy to rock up and chair it, but it was a fantastic way to see that people working together. Given that we are groundbreaking, we won't get everything right all the time. However, I must absolutely commend colleagues for the way in which they came with a system level mindset, but also with the ability to challenge in the right way. We heard loud and clear that there was a need to avoid any sort of duplication, joining up work streams around the three organisations, and the quality improvement committees of those organisations were going to be key. We decided to do some exciting things, but those will be clarified in the minutes. We were hoping the minutes would be out, Chair, this week, but given ICB executive colleagues getting ready for this board meeting, those minutes are due out early next week. The work has already started as well, and after the minutes, bringing together colleagues for agenda setting, as I've already said, to sort of avoid duplication, and the importance of the forward view of that committee is going to be absolutely key. And work has already started between sort of chairs and chief executives about what that would look like moving forward. So very collaborative, done in the right way, kept at the system level, had the right level of challenge, but we heard loud and clear about the forward view and where we need to go next. That was my update, Chair, given minutes and things haven't been published, but I'm very happy to take questions, comments and feedback from those that were there. Thank you.
Order to bring in the three chief execs in a second, because at the heart of the concept is that it's a decision-making body on the basis that the three chief executives lead a cohesive view on it. Kate, so why don't you kick off?
So I think as a first meeting, it was great, and we're closing down some of the issues that we need to get to, so that we can then be in a forward-looking way of working. And we've agreed that we're going to bring back some work around a stroke end-to-end review and segmenting the stroke pathway, so that we're making improvements straight away, but also looking at improvements going forward. And we've also said we'll do some work around diabetes. So I think we've already got a forward plan in terms of the next meeting. What we need to work out between us is what we'll be able to take back to the next meeting. But it was great to see that the intention from our system is that we're going to improve together. And I think that's just something we need to hold on to through the next year.
Thank you. Debbie, what's your take on that?
I think it was a very good first meeting, and we reflected on it at our board yesterday. Colleagues really welcomed the way that Nick chaired it. Was felt to be very inclusive, and certainly your follow-up subsequently with certainly I can't speak for other chairs, but certainly our chair of our quality committee subsequently, Nick, and I know you've reached out to others, was really appreciated, because I think colleagues recognise that it's co-creating, co-crafting the future agenda. I think there's still some feedback from our non-executive directors about how do we ensure that we're really focused on what is system quality strategy rather than operational business that is, you know, Susan's referred to it earlier about the processes that are already in place. So I think there's more work to do about the co-creation of it, but we felt that it had gone really well, and it was something to be celebrated in terms of maturing system working.
Steve.
Yeah, I'd echo what Debbie has said. So Nick, I'd like to acknowledge the leadership approach and the values demonstrated by you as chair. I think it really set the scene for an integrated system improvement quality committee. So I certainly want to echo Debbie's comments with regard to that. I think what we saw was a great example of chief medical officers, chief nursing officers within the system working jointly and collaboratively together on bringing information forward to the committee. I think that's another really powerful example of the intent going forward. And the examples that Kate's given about the future agenda items that we're proposing are absolutely system-wide items of importance. So I think that they fit the intent going forward. We I think will at some point want to reflect on the membership and the attendance, and I'm conscious that we had an NHS focused meeting, which I think was right for the agenda items that we had. But the topics that Kate has kind of moved on to would have a strong public health and wider care system, as well as the health part of the system. So I think that's something we would need to give consideration to, so we could have the advantage and the expertise of other system colleagues at the right time as that develops. We I think through SWAS colleagues have identified some opportunities to ensure more timely engagement of system partners as well. So I'm sure there is some learning that we'll pick up to make the next committee an even kind of more system and collegiate one. But as an initial first of its kind, I believe in the country, I think it was a significant step. and the opportunity to build on that and take even more strategic items of consideration going forward, I think, is important.
I viewed it too as when I was there, and Debbie, the thing I think the feedback I've had too from different people who've spoken to me about it has been a great first meeting, well chaired by Nick. I can concur with that. But also, just as you articulated really well, just flushing out that bit between the assurance committees that exist within the providers and actually how this actually add values as a decision-making group, for where the 3 chief executives are bringing their clinical teams on a journey of agreement. Just needs a bit more finessing as we go forward. But that's, after the first one, I think the collective spirit was really strong. And if I can just, again, lots of thank yous today, but reach out to Mary and to Steve on behalf of the RCHT board. Thank you for that. And to Margaret and to Debbie on behalf of your board. Thank you for getting us to this point, and look forward to agreeing the next agenda and seeing the next papers in 7 weeks' time. Nick, anything else you want to add?
No, just thank you for the feedback and the comment. It's all gratefully received, and I'm very grateful for the feedback from colleagues, and I would agree with everything that's said. And onward and continued. Thank you.
I've just spotted Ali had her hand up.
Yeah, sorry, I wasn't sure if you saw it. I just wanted to pick up on Steve's comment around kind of broader system partners, and just think about how we might do some joint work with this committee and the statutory overview scrutiny committee in the council, which has that kind of responsibility for social care, public health and health as well. So I just wanted to, and I think I might have mentioned that last time as well, but I just wanted to make sure we weren't duplicating work, and maybe the committees could come together and do some joint work. Thank you.
And I know, Mary, you may join me in this. I know if Margaret was here too, she probably would support this comment. At the heart of this will be a truly functioning system executive group. And that SEG group, in order for this to really work, the system quality group, it's a prerequisite that SEG functions. I know it probably is, but I'm just trying to make them, if SEG really functions well, then this will function even better, because SEG is much broader than just that. So happy with that?
Mm-hmm.
Lovely. Thank you so much. So where are we? Gosh.
Sorry, Chair, I'm not sure that answered my question. Was that an answer to my question? I'm sorry. Or my point?
I think what we're going to take away is your observation that at the appropriate moments, the broader committees need to be done. I think that will be done as part of the SEG group, working with Nick as the chair, in what the committee is looking for and what membership. Once you know what the agenda items are, then you know who actually should be coming for each of those agenda items. So
I'll pick that up with our democratic services in the council, because they won't be represented at SEG for that kind of conversation about the crossover. It was just particularly on Steve's point around care and public health coming to that committee. So I just wanted to be clear.
Yeah.
I can pick it up with our democratic services. Thanks.
I think it's a really helpful question, and I think it also it isn't directly answering your question, but there was a discussion about ensuring that the equivalent quality committees within CFT, RCHT, and Neil's already mentioned the ICB, are ensuring we're not duplicating. So it might be useful, Ali and Kate, if one of the next steps we take is look at the existing forward plan for the Health and Adult Social Care Overview Scrutiny Committee, and the intended forward plan for the System Improvement Quality Committee and the 3 organisations Quality Committee, because that might give us some pretty quick oversight, Ali, on if there is any overlap, and might be a route into the discussion that's just been described.
So I really welcome the question, Ali, and Steve's further information. I think we need to be mindful of potential overlap, but also gaps. Yeah. So if I'm thinking about what's going to go on that agenda, then certainly I think as a system, we need a themed agenda around our high suicide rate. Rachel picked it up earlier, but that is a topic that actually I would imagine that we would want to invite, if we were a mature committee, other parties to be part of it, because it would not be for statutory members to sort on their own.
So just think about this. How long is the meeting? That one was 2 hours, had 4 agenda items on it. If all the stuff is all pre-agreed and it's not a problem, you could even have an hour's length meeting. If you're going to actually have a lot more debate, you need to factor that in. And they only meet every 8 weeks. So because they're rotating with the other quality committee. So I think planning it out is going to be part of its success, really. Tracy?
Yeah, I was just going to say that I think also we need to distinguish between the roles of the scrutiny and oversight function and the role of the committee, which I think is slightly different. It's not there in an oversight and scrutiny role. I think it's much more there to solve common system issues that are impacting on quality. So we probably just need to be clear about the distinction between the agenda items as well and the roles.
That came loud and clear in the feedback, is that it's not a criticism, but still some of the papers were assurance orientated, when in fact that's possibly what your colleagues are talking about in terms of bumping into what the quality teams are doing.
I think Tracy's making a different role around the Overview and Scrutiny Committee. So we need to be really clear legislatively which bit of our system is responsible for which bits of system responsibility. So the role of the Oversight and Scrutiny Committee is well made for social care and for health, whereas this is around the delivery across our system of linked service actions. So it could be that we would be wanting to have the community sector more broadly in the room with us for some discussions, and for social care and maybe housing for other discussions. So I just think as we set the forward plan, we can then work out who needs to be around the table. And as we go into that bigger piece of work around the ICP, Ali, around the role of the Health and Wellbeing Board, the ICP, then we can look at genuine scrutiny and oversight across our system.
Signal, you're nodding. Happy with that?
Yeah, that's what I was going to say. It's that forward plan and making sure all the right people are involved early enough to
Sorry if I
contribute.
misunderstood you, Tracy. Did my colleague here answer it better than I did?
Yeah, it's good. Yeah.
You're happy with that? Very, very good. Okay, lots of positive stuff going on there. Right, are you happy to break for lunch, colleagues? So could I ask you to be back prompt start at 1:15, please? Thank you very much. Thank you. Thank you very much.
Yeah.
Welcome. It's not often we have the opportunity to do a deep dive, so thank you for facilitating this today. If you can introduce yourself in a second. We've got a presentation. We've suggested that we've got about 40 minutes for this. Encouraging you to leave as much time as you can for a Q&A at the end, but it's not often we get the chance to do a deep dive, but I think it's a real great opportunity. So welcome, Wahid, and thank you so much for doing this. Over to you.
Thank you very much, and thank you very much for the invite to come and present here. My first aim is to keep you all awake for the 40 minutes. Hopefully I'll get there. But the second and more important aim is to make sure that I can present an argument which highlight how clinical services do better with research in them, and research does better with clinical services in them. I think we all sign up to that principle. It's almost like the Moses principles, literally, but realizing them is a big challenge. So I'm going to use our own service, intellectual disability services, adult intellectual disability services, to highlight this. First, my conflicts of interest, there are numerous. I can spend 40 minutes just talking about them. Basically, I'm a professional beggar. Like working for a university makes you that. But the idea is it's all ethical, and it's presented into developing grants and bringing in the money to develop projects. While this is a deep dive, it's still going to be a whistle-top tour of lots of things and generational issues around clinical and research issues which influence people with intellectual disability. So without much ado, and I hope if anybody struggles with my Indo-Cornish accent, do let me know. My children say it's more Indian than Cornish, but that's fine. So the first thing is, why are we here talking about intellectual disability? So people with intellectual disability in the UK, it's around 2% of the population. Now, this population has certain needs and certain issues which separate them and require a better and a much better understanding of their issues. So the first thing, physical and mental health morbidity. So people with intellectual disability have 3 times higher mental health, major mental health issues, schizophrenia, anxiety, depression, approximately 3 times. Physical health, on an average, a person with intellectual disability has 12 chronic conditions. So they're going to come to each one of your services sometime or the other and knock on the door. So 12 chronic conditions. And even if you prescribe sensibly and you get 12 people, 12 medications, 12 doctors giving 12 medications, who can sustain that? I mean, that's going to be a challenge across a lifetime. Why does that happen? Because, of course, people with intellectual disability have significant challenges around impaired communication, impaired cognition, and that impacts on their choice. So choice is made for them. And this is an easy way out where we can make those choices in a kind way, but maybe not the right way. When we give all these medications, do they work? Do they actually make the person better? We call that, in a way, forced normalization, where actually the person might actually become better, might start to make choices of grabbing stuff, or they wouldn't have had the social skills, but that then comes across as challenging behavior. So is that medication side effect, or is it actually their true personality which requires help? All this unpacking needs to happen. Finally, diagnosis is challenging. In a way, I think that's a good thing because it keeps me in a job. But of course, with the diagnosis being challenging, knowing what the problem is, you might have toothache. We know it's toothache because we can tell, and we can go to a dentist, etc. But for a person with intellectual disability, the toothache might come across as a dull ache. They might throw orange juice in the morning at their carer. So instead of seeing their GP, they might be carted off to their psychiatrist, who actually will think, oh my God, this guy is very anxious, he's not sleeping well. So that's diagnostic overshadowing. And we need to understand where and how we fit the right systems to ensure that the right doctors, right clinicians get the right persons in front of them in a way. Finally, premature mortality. Take a breath. What we have is in UK, which is an economically developed country, with NHS, which is a socialist, basically social this thing, giving care to everyone. Women here can aspire to live to 81. People like me till 79. People with intellectual disability, 63% of people with intellectual disability will die before 65. That is unacceptable in today's world. And I'm going to go further into this and talk a bit more about it. So, setting the scene here, what I want to do is, of course, I can talk here and sort of filibust here, but I want to take two clinical pathways on which we have been working. We've got something like 8 different ones, and highlight the background, quantify the need, and show what Cornwall has done, how that has extrapolated nationally and internationally through research, led to innovation, and how have we managed to bring things back to the same group from which it all started. So the first group, which I want to talk about, is people with intellectual disability and epilepsy. So just to set the scene, people with epilepsy, the prevalence is 1% in general population. In people with intellectual disability, epilepsy is 22.5%. So nearly a quarter of people with intellectual disability have epilepsy. Why is epilepsy important generally? Shift again, before I get into that rabbit hole. It's basically what you have is asthma. 5.6 million people in UK have asthma. 1,300 people on an average every year die because of asthma. 600,000 people have epilepsy. The same numbers, around 1,250 to 1,300, die because of epilepsy. So epilepsy is a 10-time higher killer. When it comes to intellectual disability, automatically that raises your problems because you've got 25% of them there. So when we know physical and mental health morbidity, even compared to their peers with intellectual disability, the average age of mortality for a person with intellectual disability and epilepsy is 48. Where did we find it? We found it here. We worked it out, and we worked it around population scores. What we also recognized is that epilepsy in a person with intellectual disability is a bellwether for multimorbidity. They have higher rates, higher range of cognitive deficits, more likely to be moderate to profound, have genetic issues, more likely to be in social care, more likely to be harmed. We also know that we spend a lot of money on them and we get very poor results. So these are things which we are finding out, shifting the unknown unknown to the known unknown in a way. 30% in the general population with epilepsy are treatment resistant. It's 70% in people with intellectual disability and epilepsy. On an average, with regard to behavior, drugs, etc., costs are significant. Avoidable ED admissions. So generally, people with intellectual disability have 5 times higher rates of ED admissions, which are avoidable than general population. Number one reason, in 40% of people, it's epilepsy. So you can see where it's going. The premature mortality, when it comes to, we have got LEADA, I'm sure everybody here is familiar with LEADA. It's the national inquiry which is ongoing, which looks at every single death between the age of 4 and 74 in a person with intellectual disability. And LEADA has shown that comorbidity of epilepsy in the premature mortalities cohort, which they've looked at some 10,000 deaths. It's around 35 to 42% year on year. So that's a very important group there, which requires further understanding. It's like a vase with cracks. And the more cracks that happen, the more fragile they become. And that research, which we did, was very much about engaging nationally with 10 other national trusts to understand what are the risk factors which separate those who are living with intellectual disability and epilepsy and those who are dying. So we looked at 910 people with intellectual disability and epilepsy and compared it with 190 deaths. If anyone has problems with sleep or insomnia, please download my papers and read them. They're great. An average paper will give you 3 days of good sleep. I can assure you that. The thing which is there is each of these papers are freely downloadable, but they will give you the data and the challenges. So we found risk factors such as lack of care plans, lack of epilepsy reviews, multimorbidity, and antipsychotic use. So high levels of antipsychotic use, which is a bit counterintuitive. And we have presented that at a national level and led to creation, looking at deaths in epilepsy, to the SUDEP and seizure safety checklist, which emerged here in Cornwall. Now all this compilation has helped shape national guidance. The Royal College of Psychiatrists, NICE, NHS Right Care Toolkits, all pick up on this and talk about the models of care which has emerged right from the coalface, from our understanding about how things have shaped for this population. And the learning models have moved internationally, where ILAE, which is the oversight organization for epilepsy, has picked it up, and we have written seminar series. And the most important thing is it's developed into innovations such as apps, and I'll show that to you. You must all be asking yourself by now, so has it made any difference locally? Well, yes. On an average, in 2010, you would have around 3 people with intellectual disability every week attending ED. Currently, it might be around once in every 2 months or 3 months. We have got even better data. People dying. For the numbers that we have, we should, for this population, we should be losing around 3 to 4 people a year in our population. We have lost 2 people in the last 10 years. So clearly, it's not that we are working miracles. What we are doing is doing simple things right, hopefully, and putting it into evidence and justifying why we do it and how we do it. So this moved across to the SUDEP and seizure safety checklist, which is now being used across UK, and it's basically good practice. All neurologists and epilepsy nurses are advised to use it. It's part of the Right Care National Toolkits. It's also being used in 10 different countries where it has been put to practice. And from there emerged the app, because we thought, why should it just be about intellectual disability? It's also about general population. So the risks are very much similar. So we created that risk profile and we moved it into an app. The app itself is owned by a charity to which we have contributed, and we get the data. But also, very importantly, at this moment, there are 5,000 users of the app who put in data every 3 months to update it. So that's sort of like my pound of flesh to analyze and do things. So here's something about the whole project. was recognized as one of the 70 top inventions in NHS 70 when they did their promotion. Clearly, they were scraping at the bottom of the barrel, but well, it definitely appeals to my narcissism and vanity, which I've got oodles of. So we went for the BMJ Awards, and we won a BMJ Award for neurology for the checklist and how we created that. Then we again went back to the BMJ Awards for the EPSMON app, and we won it for education and training. So we've been very successful at a national scene with that. And the BMJ Awards is basically considered the Oscars of the medical world. So, but also what comes out of that research is research. We are understanding the profiles of people who are putting in data. This is people who are on the streets, there, and there, who are putting in data. And we are getting to understand what are the challenges in communicating to them, communicating risk to them, because they are living with these conditions. But what does that have got to do with people with intellectual disability? Well, it started with people with intellectual disability, and it only made sense to go back to them. So now the app is getting redesigned for people with mild intellectual disability to use for themselves. So that is your innovation cycle, the last 14, 15 years, where we have progressed from Cornwall, taken it all around the globe, come back here without moving much, and got it all done there. So that's one example of a pathway, which then has also helped shape all these national guidances. So you can find significant mentions and this thing from it around rescue medication training, how epilepsy has to be done, the right care toolkit, NICE guidelines, and the Step Together toolkit, which basically allowed us to start understanding communities. How do you keep people with intellectual disability and epilepsy safe? And this is where Dumbledore comes into feature. So you can choose between the easy option or the right option. And basically, fools go where angels fear to tell. We chose the right option, and we went with that. And we created a toolkit. The toolkit has now been adopted by Epilepsy Action. It basically looks at a community as to how good a community is, not a service for a person with intellectual disability and epilepsy, because they move between different people. They go to social care, they go to placements, they go to the bowling club. So how do you make sure there is a informed community? So it's about capable communities. So we tested it in the Midlands. Of course, you don't test it on your back door, something new. You always test a new bomb in somebody else's pitch. So that's it. So the Midlands, we tested it because they were craving and they wanted it. And we found that basically Midlands, there was so much differences between the ICBs. So one person, you should be getting the same care if you're in ICB here or in Devon, but that's not true, and we know that. So for the first time, we started outlining what the challenges and differences are. So of the Midlands 11 million population, looking at 8 domains, the overall score was 44%. So lots of areas to improve on. So it again moved the unknown unknown to the known unknown for them to work on, and they are doing those sort of work streams working there. Then we brought it to Cornwall, and we tested out Cornwall. So bring it back to us. And that showed that we are around 60%. Yes, we have, like Robert Frost said, miles to go before we sleep. But we are getting there. And it's good to know that we are 60%. So now I'll shift channels to the next pathway, which is around mental health and behavior in people with intellectual disability. Everyone here would have seen the top news, and it still plays up, Winterbourne. We had our own BUDOC, those who are grey enough here like me to have known that BUDOC happened, but Winterbourne took over. And since then, there has been scandal after scandals. And one of the biggest things which emerged from Winterbourne was a real questioning as to why are we doing this to very vulnerable people. And we found that not just are we putting them in hospitals when not needed, but we are also drugging them up to their eyeballs. And nearly 30% of people were on antipsychotics and psychotropic medication without a reason. And that led to a lot of soul searching. How do we sort of take this away? How do we sort of make it go away? Because this is generational. I can't just stop people on medication because there is a need. They might be mentally unwell. They might not. So how do you unpack this? And how do you sort of diffuse this bomb? So there was a lot of soul searching in all the different organizations, and basically lots of recommendations and reports. what you had to go down to is very much the basic structure, which is how does prescribing happen? So you got a person with intellectual disability, they don't like orange juice, and that's given to them instead of apple juice. They throw it at your face. Somebody says, well, this guy is mentally unwell, cart him off to the psychiatrist. Psychiatrist got 15 minutes. Here's a drug which will make you happy, off you go. But then nobody reviews. So that's where things started to change. And we brought in the MDTs, the team. They do the assessments. They understand, is it communication? Is it distress led by behavior? And then feedback to the psychiatrist. This should be the model of working. And then we have to feed back to the GP. The GP makes sure the health is well, generally all okay, like the dental check, etc. But none of that was happening. And when we looked at the various reports that came out, everyone agreed on one thing, that it's wrong to keep prescribing. But no one said, how? How do you take away medication from those who have already been put? And how do you stop prescribing when on a Friday afternoon you get somebody's placement breakdown? This is where, again, us in Cornwall, the fools who go where angels fear to trend, stepped up. And we did the national study, the first Tom study on this. And what we identified for the first time was that housing, issues of housing and placement play a major role. If you really want to get things right, you have to start from the basics and work from there. And I think David explains it best. I'll let David explain it. So David was 41 years with mild ID. In 1995, he was arrested for assault, possession, and he was thought to be psychotic, but reviews didn't suggest any obvious diagnosis. He was put on a depot, Zuclopentixol. Every 15 days, he used to get jabbed. And the police would always pick him up with dangerous behavior, and they would then phone the mental health team for mental health act assessments for mental illness. And David himself, when he would sort of get into debts or he knew that somebody's after him, would come and knock on our doors to say, I need help, I'm mentally unwell, I've got intellectual disability and mental illness. So it became a card of entry. And social care basically said, well, no, he's got mental health problems. You have to put him in a hospital. And when I started talking to him about withdrawing the depot, because I couldn't find any evidence and testing it out, my only complaint has ever come from him. So that was the challenge. But we put together a team, including social care and housing, and David can explain what he...
My name's Dave. I was on Clopixel and chlorpromazine for quite a long time. Before I was on Clopixel, I was on chlorpromazine. They gave me injections of that a couple of times, and they gave me the tablet form. And then when I come to see you, you decided, well, we all decided that I should come off it. 22 years.
And what were you put on the injection for?
No diagnosis at all.
Okay. Did you feel that the injection helped? Or were you...
No, the injection didn't help, no.
Okay. And
I wasn't happy at first, but Adele assured me that it would go all right, so I took it as Adele's advice and kept myself busy and stuff like that. And then since I've been off it, I've been a different person, haven't I?
You have, but I think you were scared of coming off it, weren't you?
Yeah,
It was a
I
scary
was.
thing because you've been on it for so long.
Yeah.
That you thought your mental health would deteriorate, and it hasn't, though, has it? You've been fine, haven't you?
Yeah.
And you've succeeded in many.
Was working in a charity shop, last I know of him. So that's his story. So it's basically make in Cornwall, sell worldwide. This is our experiences. We have done a lot of work around how to withdraw people from medication, how to stop them from going back into hospital. Where does patient choice come in? And how do we actually look at big data to understand how prescribing trends are happening? So that covers a lot of this thing there. Then it's basically transforming care, which you would all heard, stopping people from entering into hospitals. We have not had an intellectual disability specialist hospital since 2007. At present, we are only 2 people out of county. We are one of the best functioning counties. And our last admission to an intellectual disability specialist hospital was over 2 years ago. And for what, again, the stats, I have heard from Graham Carr, who is the Southwest, he believes that we should be having 6 admissions per year for Cornwall. So either we are doing something really good, or we are not admitting people who should be admitted. You have to always think the other way. But hopefully it's the former than the latter. And again, we publish everything. We peer review and publish it so that others can learn both from our knowledge and mistakes. And we have developed new tools from this called Connect Behaviors, the Purple Book, to help communication. Just putting things in big letters is not easy read enough. You have to work at a cognitive level with individuals. And again, we got, as I said, the vanity markers, HSJ, the BMJ, we were shortlisted there. But there is so much else which we do. Things like the bowel problems in people with intellectual disability, we research into that, the bone health in intellectual disability, social care impact, and where does it lead to with regard to larger, creating humanizing healthcare and working from there. So all this is very important stuff, and what it has led to is significant achievements and accolades. I don't know if others are performing much worse than what they should, or we are performing better than what we should, but we have been the teams of the year for different reasons across in the last 2-3 years in the Royal College of Psychiatrists. But the biggest accolade for us, which I hold with our trust, is that we were the first QNLD, the RC Psych benchmark for over 100 standards. We were the first one in the country to get it for learning disability community services. I do not believe that we could have got it without research in the back pocket of us. And that's where CIDA comes in as a research-oriented system. If I have 2 more minutes, I can just very quickly highlight what research we do and how we do it. So this is where I become grandiose. So we basically look into genetics, medication, big data, technology, AI, and apps. We look at precision medication strategies, medical strategies, smart housings, social environmental changes. Nothing's beyond us. Personalized holistic care is what we want to achieve. And we are into things like social robotics, etc. And the center to that is co-production, involving patients and families. Very, very important in doing this. I'll give you an example here, because this is what it is, co-production, because everyone wants something. Nobody's really clear what. We all go in with our agenda, and it's about getting what we want at a different levels. So we have published a lot on co-production itself, about how to work with patients and to make it such that they are happy, because then they use it themselves, which is, I think, an important thing. This is an example of prediction of seizures before the seizures happen, and it's mathematical modeling.
At Neurognostics, we are developing mathematical and AI tools to unleash the power of information contained within the electrical activity of the brain. We want to bring this power into the homes of people with epilepsy to enable them to record their own brain data without repeatedly attending clinic.
So why is this important?
Neurognostics technology is not reliant on observing seizures. Instead, our AI algorithms reveal this information from seizure-free EEG. Excitingly, we have evidence that our patented BioWeb seizure risk score can indicate whether a person with epilepsy is responding to their medication. This uses only short segments of EEG data that can easily be collected at home on a daily basis to personalize treatment.
So if we get an EEG from a person who's distressed and it's normal, this can actually tell us where it's going. So we are also using AI technology to understand nocturnal seizures at night with regard to when people are nonverbal, are unable to communicate. This connects back to some 7,000 different seizures and tells us how close to a seizure it was. So we published on that and we have worked on that. And most recently, we have been working on this, which is sticking needles into people's heads. Sounds horrible, but it's basically in-derived with the neurosurgeons. It's retainable EEGs so that we can differentiate between behavior and seizures now. This is going to be a potential game changer, hopefully. So. for something like 6 months, and we get the recordings of when things had changed, and we can calculate and see if families thought it was seizure, we can actually say, maybe not. So we stop then drugging people up, hopefully, in the wrong way. And I'll end with Paula McGowan. I'm sure everybody knows Paula McGowan. She was the one behind the Oliver McGowan Autism Training. She's a very close friend of mine, and she is the PPI lead for SIDA. She will tell you what our projects mean to her and what it would have meant to Oliver.
Hello, my name is Paula McGowan, and I'm the mother of Oliver McGowan, a young teenage boy who died an avoidable death. Oliver had an intellectual disability. He was also epileptic. And he was taken into hospital having a focal seizure. He was anxious and he was agitated. And because of these behaviours, Oliver was prescribed an antipsychotic medication, a medication he was known to be intolerant of, and one he simply did not need, and it took Oliver's life. Now, hospitals, by their own nature, are scary places. They're busy, the smells, and it will cause sensory crisis and overload to a lot of people like Oliver. You know, stress does actually induce further seizures, and of course the seizures induce further behaviours. This project offers the ability for people like Oliver to be monitored safely within their own homes. It allows our clinicians to collect accurate data on what is really happening, which enables them to give better healthcare to people like Oliver. It can, and it will save lives.
So that's where I finish in a way, because people with intellectual disability and needs are like this elephant. You can get them on the ball maybe and walk away, their needs met, but they will slip off. So you have to have ways and means in which we keep a surveillance. We keep getting them on the ball again and again, trying to make them stay and learn the balance. It's challenging, has to be done, and we can't do it with what we have to bring into account the latest technology, and they can be the vanguard. They should be the people who we should be investing more in, because they can set the tone for the rest of the population. They can set the tone for you and me in how complex care is managed. When I get dementia, I would like to know that there has been certain ways and means in managing complex care, not again with regard to symptom management. That's where we struggle. Anyway, I'll shut up there. And this is Mansell, who was one of our biggest leaders in the world of intellectual disability. And this resonates for me very well. We are not there to give high quality care. We're there to give good enough care. I want our patients to have good enough care and their families. And for that, our team and our trust, Debbie, Adrian, everyone sort of pitches themselves in. And I think that, and the community has been very kind to us, whether it be from RCT and others. May it long continue. Thank you.
Thank you. Excellent. Thank you so much. So, Debbie, would you like to make any observations before I open it up to the floor?
Well, I'm just, in the whole trust is incredibly proud of Rohit, and also Richard Larn, who's the director of CIDA. And because it's a small population, we often don't get a chance to talk about or have a really in-depth conversation about what are the needs of this population. But in inviting Rohit today, I had no hesitation, because I think that he strikes many of the notes in his talks that actually we should be thinking about at a population level as an integrated care board. I think he's probably resonated with every single one of us, no matter what hats we're wearing. And I'm also very aware that the integrated care board has a statutory duty to promote research and innovation. And I think Rohit is a member of our, when Kate says we're all ICBers, I think we should be celebrating that we have very forward-thinking clinicians in our midst.
And did you say it was Richard?
Richard, yeah.
Do you want to join us, Richard?
Yeah.
Come up so I can see you.
This is also clinical leadership in action, isn't it? So, you know, when we're talking about our passionate clinical leaders that should be making it impossible for us to resist doing things, This is it.
Is there anything you'd like to add before I open it up to our colleagues?
I'm sure you've got questions, but I think the key thing is it takes time. I think Rohit spent 15 years building things up, and that is really coming to fruition and having an impact across the whole country. And we really would like to see CIDA grow. He's brilliant at networking with colleagues around the country to collect data and work with him. And our ambition is to become a WHO collaborating centre for research in learning disability. Rohit's the leading learning disability psychiatrist academic in the UK now. And the UK is the only place where intellectual disability is a speciality. So that, we could be a real world leader from Cornwall.
Excellent. Thank you very much. So I've got a number of people who want to ask. So Tan first.
Firstly, I'd like to say it's one of the most powerful presentations that we've had since I think we had the population health management jaw-dropping moment. So look, well done for all the work that you've done over the years, and it must have been a bit of a battle of persistence at times. So really, what I'd like to know is, when do you think the big tipping points came, and what are your hopes for the future?
I think that's a very interesting question, but just to clarify, I'm just the tip of the iceberg. I couldn't do what I could do without people coming in to lend a hand here, there, and lots of people like Mike Wilcock. He has joined into projects, published papers with us. He's the head pharmacist in RCHD. So it's just little things where we can actually harness energy. And I think it's very much about building. I think the tipping point very much in intellectual disability, we are happy with it. We have managed to actually even spread our illness nationally. So we got something like 20% of all intellectual disability consultants nationally now working with me in research. They all do their bits like data collection, reviews, this thing. So I think exactly what I would like to see is this sort of research incubation, which happens. That research is not something which happens glorifically in Cambridge or Oxford. It's not something which happens in a lab. It happens in front of you. You see an interesting case. Most people know it's interesting. They know that if it's been challenging, it's challenging because you've got 20 years of experience, but you're still coming home worried that that person's going to die. That means something's challenging about it, but you don't know how to write it up or tell it to others. That's where we can help. We can help with some of the really brilliant staff are in the knowledge spa, in the library. They have been brilliant with regard to doing literature reviews, feeding in. So almost that you start getting this shared sense of ownership in a community and bringing people in. I think as I said, I think research should be like air. We shouldn't even be thinking as clinicians, we should do research. So research happens automatically.
Can I therefore move you on to a question from Stuart, please?
Thank you. Thanks, Rohit. Hi. I think the research and the way that you've been leading nationally, internationally is something to be extremely proud of, and something we should be celebrate in Cornwall. It's probably something we don't do loudly enough. A lot of systems shout about all of their achievements, and we don't necessarily do it here. It's testing you out. What I would just like to say is that working personally, clinically with Rohit, with certainly one of my most challenging and vulnerable patients, the thing that always strikes me is both the personalised and the MDT approach, Rohit. So I think the last time we did an MDT, you were sat in this person's father's home. There was, all the carers were involved, mum and dad involved. And I just think that there's a lot to learn from that degree of personalization, that co-design, and that MDT approach. And there's something that I think we could all take away into other aspects of our system as well, be it frailty, other mental health aspects. But certainly Rohit's both a very clever pioneering innovator, but also is on the ground co-designing with patients and with carers and with the MDT. So that's the bit I think we should also be celebrating.
Happy to celebrate. Ali.
Thank you, Chair. Thank you so much for that presentation. It was really interesting, and I can't believe there was so much work that's going on in Cornwall that I wasn't aware of, so I feel ashamed, but I'm really glad that I've heard it now. And I just wondered, you mentioned social care a few times, and I just wondered if you are working with Karen Hooper, for example, the kind of head of working age adult commissioning, because we have a whole program around personalisation at the moment, and we have a co-production steering group, which is the majority of the people on that group are residents with lived experience of our services. And we're doing a huge piece of work at the moment, and I just wondered if there was an opportunity for us to collaborate and join up some of those dots, really. Thanks.
Oh, definitely. I mean, there's a lot of money coming into social care for research, so that automatically is a magnet for somebody like me. But equally, Kevin Benbridge and we've been working with Emily and others in developing projects, and we used the champs as one of our major groups to help feedback. So we are very much enmeshed in that.
Okay, thank you. Mary?
Thank you. That was very enlightening. Do you do anything with adults with an acquired, often traumatic brain injury, where I'm a trustee for Headway Cornwall, and a number of our clients are all on anticonvulsant medication, and it would be useful to know whether that's inclusive as part of what you're talking about?
Is it brain injury?
Yes, maybe from whatever, a whole variety of different causes.
Yeah, unfortunately, that's not the system I ventured into yet. So.
Okay. Janice, you're not part of the presentation, I'm afraid, are you? Sorry? Janice, is she part of the presentation?
No, I'm not. No, I just...
No, I'm afraid
I just wanted to ask a question, if possible.
Can you just give me some, is it really quick? Because you're a member of the public, I take it, are you coming in?
I'm also an NHS provider as well. Just an observation, if that's okay.
Okay, be very brief, please.
Great, yeah, sure, no problem. Thank you for the ICB for having this presentation as well. It's been really helpful. Certainly, research in clinical practice is really, really powerful, and we run a fledgling sleep service within CAMS and in LD in Cornwall, and we see incredible results from the point of view of medication reduction and service use reduction. And I noticed that you made some jokes about sleep. I just wondered, Rohit, if you'd actually considered sleep in any of these pieces of research, because it is something that can be applied to general population as well as to the specific population that you talked about.
At present, pretty much hands are full. So, but I think this is definitely something which we want to take forward and venture into, because I think the whole medication optimization issue, especially with the intellectual disability with STOMP, took off more as a hype, and everyone was signing up STOMP pledges, but really nobody knew how to take off people who had complex needs, multiple antipsychotics. And one of our projects just now has just shown, we have looked into nationally people being prescribed 2 antipsychotics without a reason, and what's actually happening with them. And that's going to show us some interesting findings. Right. But I think these complex issues and complex problems, people are on a treadmill. A, we have to know how to stop the treadmill, and B, we need to stop other people getting on the treadmill. And that's quite challenging, because even with medication, the work that I did, I can self-criticize it quite convincingly, is that it's 6 months, 9 months in duration. How many of them might have got back already onto other medication? That's the challenge. So there is wheels, wheels within wheels.
Thank you. So 2 questions from me at the very end of this, and I'm going to pose them to Debbie and to yourself. You can go last, if that's all right. You can say, what would you like from us?
Where do I start? No, I think money is not a problem. Funnily enough, though Richard will rap me on the knuckles for now. This must be the first time, but we are doing pretty okay money-wise. I think what we want to do is, this might be a bit grandiose, but we want to develop an ecosystem to facilitate research. So we don't want what we are finding challenging is engaging people, where we have to go and have those multiple conversations to say, can you do this help for me? Can you recruit this patient? Can you do that? We almost want people well aware that they can actually engage with us, and research should be part of their clinical learning in a way, if that makes sense. So
it does. So my question to Debbie.
Yeah, so I think it's research is everybody's business, and it isn't just the domain. So as much as I'm really grateful that we've got Rohit as a professor in our midst and Richard, We've also got nurses and therapists engaged now in research, and one of our nurses with lived experience had his first paper published recently, which was fantastic. So I think it's trying to promote research as everybody's business, the real importance of co-production of research from the outset with subjects, which is absolutely key, and to encourage, whether it's within intellectual disability or other areas, there's a real body of research growing in Cornwall. And having come from Oxford, I think there's something about, we just need to really celebrate what we've got so we can continue to build and grow that momentum, because as Rohit has said, he's bringing money into the county to fund further research.
You're always welcome, by the way. Kate.
Can I make 2 points? So one's about so research is different from improvement, is different from innovation, but there is something around professional curiosity that winds its way all the way through those things. And we have a duty to promote innovation and to promote research, but we've also got a duty, a new expectation that we'll have continuous improvement across our county working together. So there is something about this, and Chris around a clinical summit, about how are we getting that professional curiosity and the time and space to use it across all of our services. And what you describe around what Stuart describes working with you around somebody who could do with the help of everybody. There are models around the country where mental health services would do that liaison service into general practice, but there's also places where cardiac consultants or respiratory consultants or respiratory nurse specialists would do the same. So one of the, I visited Deloitte yesterday, and they were talking to me about things that are happening around the world. And one of the conversations I had with them was around type 2 diabetes, and just a curiosity we've got. If at the point of being diagnosed, you're offered metformin, other tablets can be prescribed, or you're offered a personal health budget and the ability to engage in diet, exercise and dietary advice, and then you do a longitudinal evaluation over many years, because the hypothesis would be community connectedness would make this side of the research healthier. Unfortunately, they've already done it in somewhere in America, and it's true, it does make it happen. So how can we bring some of that curiosity with a hypothesis, with a clear piece of work, so there can be more researchers like you across the whole of our county?
So what am I going to do?
I could possibly, one of the things...
Maybe just 1 second. So Debbie, one of the things I wanted to ask you, because you slightly jumped the gun on what I was going to ask.
Fancy asking a future question.
No. I had a supplementary to it, which was, we've got John Sindel in terms of research and innovation and that kind of thing. We have had Rohit today come and talk about research and the importance and the growth and that kind of thing. I guess I'm looking for an action out of this, because I completely get exactly where you're coming from. But the reason why I asked you the question, what do you want from us, is that other than having thank you very much for the update, what do we get out of this in order to be able to make sure we can help back? And what is the action that comes from it? So could I just turn to you before I ask Rohit, what do you think the action that comes out of today?
That's a really good question. I think it's probably what we all collectively need
Okay.
to have a conversation.
Okay, no, that's really helpful.
Rope, we have got a new post in our redesign, a Director of Innovation, Research and Improvement, Andrew Abbott. So I think as an action, it would be really useful. I think we should give Andrew a little bit of warning, but for him to coordinate and give us a heat map of the research that's going on, which has been gathering.
Shall we pick June or July? Ask him to come back with John and maybe Rohit or colleagues and give us a...
So it's a joint appointment with the Academic Health Science Network, and we've got PRIP as well as the Health Improvement Network as part of that. So maybe we could ask John and Andrew, with Rohit, if you're available, to come back.
Does that work for you?
Sorry, the noise, I've got bilateral deafness. It's sort of...
No, that's okay. So what the suggestion is that we invite you back either in June or July with John Sindel and Andrew Abbott to be able to give a more holistic view on innovation, research, development. And from that, we can have a time to consider not just the presentation from you, but what next? Where does this take us? What do we want from this? And do that. Would that work for you?
Yeah, I think definitely.
Lovely.
Anything that can promote this would be a very good.
Steve, thank you.
I strongly support that. Rohit, I'm Steve Williamson, Chief Executive of Royal Cornwall Hospitals, and I think that the presentation topic was outstanding, and then the broader discussion about facilitating, nurturing and growing research across Cornwall and the Isles of Scilly is fantastic. I'd just like to suggest we broaden that group of colleagues who would come back in June or July, that there is a range of outstanding research underway, that there's a really active research community within Royal Cornwall Hospitals NHS Trust. There is across other aspects of Cornwall Partnerships, NHS Foundation Trust, and in primary care. So I think the opportunity to bring all of these together to deliver that ambition that's just been described would be really powerful.
I'll tell you what, you could take this away, colleagues. But one of the things that I'm thinking through now is that, you know, we talked earlier on about having an away day. But rather than snatch half an hour or 40 minutes, this sounds like a sufficiently deep strategic set of issues in an informal, almost structured but unstructured way, that if we could find a date that would work, that would be possibly a way forward.
And can I align it to the conversation we had earlier about the programmes of care? Because, so we're going to have, I can never remember whether it's 6 or 7 programmes of care, but one's mental health, learning disability and autism. So within that programme of care, it'd be great to see the research portfolio that sits under that programme of care. For long-term conditions, it would be great to see that, because there'll be a cross-fertilisation, won't there, between the research portfolios. So that'd just be great to bring it all together.
Leo?
Hi, Rohit. I'm Neil Walden. I'm non-exec on the board. I'm fascinated by the use of the app as an example, not a substitute, as an example of personalised care at scale. The ability to help someone, and I'm assuming motivate them more to self-care better. And for me, type 2 diabetes is an ultimate example of that. We've got examples in Cornwall where a whole practice is putting people on coaching with healthy eating rather than metformin. But being able to translate that at scale is going to need a bit more than either lots of people or really good use of an app. So I'm really interested in that approach.
Okay. It's really interesting that you say that, because even though it's the most successful app in the world of epilepsy, it's failed. That's my belief. The reason for that is we got 5,000 users every 3 months putting in data. What's stopping the 595,000 users from putting in data? Because they know of it. It was on BBC, ITV, you name it. It's been on there. It's been publicized by the charities. Every epilepsy charity publicized it. But what it does do is it shows about exactly what you said. Where does our responsibility as clinicians stop? We can take the horse to water, put a straw into it, but can't make it drink. Then, well, that's about it. So this is where I think we are sort of working on. But yes, you're right. I think we have to use it. Will be a significant string in the bow, to say the least.
Thank you. Final observation, because we're running out of time now.
It's just an observation, and possibly for something else to consider bringing back to the board. In September, we've penciled in a date for a clinical summit for the CRGs to showcase what they're expecting to do in their programs of work. And of course, it links to what we talked about earlier, the personalisation, the place, but it also links the work you're doing around the digitalisation and how that you have to design that with the workforce. So the CRG should be able to present in their independent streams that in September. So that's something just to think about, whether that's another...
Take that away, have a think about it. I think we need to, summarising for an action point, build this together into more sort of research, innovation, think tank moment, and then you can bring back from that. Okay?
Yep, perfect.
Thank you ever so much. We'll leave you. Do you want to stay in? We've got a session on personalised agenda budgets now, if you wanted to listen, or feel free to leave, but it's entirely up to you. Thank you so much for your presentation.
Yeah.
That's very kind.
Thank you very much.
Thank you.
Thank you.
Okay, so I know that, and Debbie, thank you so much for that, and we wish you a safe journey and see you on TV.
Yeah, have fun.
Just a little favour, can you wave as well? That's the wave.
Extreme challenge with curtsy.
That's very good. So thank you so much. Have a good day.
Thank you.
So I'm just sensitive now. A couple of colleagues I thought were attending.
Emma's doing it instead.
Neither Trafina?
No.
Oh, okay. So you are Juliet and Trafina for the day.
Together. It's
Okay.
fortunate for us that we didn't decommission the X-ray car, because they're talking about the innovation as a regional event and how great it is. So.
Okay, very good. So Item 14, personalised budget update. You've read the papers. Emma, over to you.
Just was going to put out a couple of bits. I mean, we've talked about personalisation quite a lot in this board. Personal health budgets and personal budgets are just one element of the personalised care model. They're all about ensuring greater flexibility, choice and control, and the person being in control of determining the support that they receive that's based on what matters to them. There are a range of different ways that we can do that through ongoing personal budgets such as CHC or one-off budgets, which we do quite a lot of across a portfolio of projects predominantly led by the VCSE actually, so it's a real emerging area of growth. You can see from the data that Cornwall's slap bang in the middle against our benchmark Southwest colleagues. We haven't yet had Q4 data in, but I would expect that to go up quite significantly because this time we've captured quite a lot of data from one-off. So I'm quite hopeful that we'll see our position move up when we see the end of quarter four data. So it's just, there's some really exciting opportunities, I think, for development and for increasing access to personal health budgets across a whole range of different places. And just going back to the end of life conversation, you can see in the paper that Dorset have actually looked at personal health budgets for end of life as a default. And that's something that we could do in Cornwall along with a whole range of other opportunities, including the expansion of one-off personal health budgets. So it's exciting really. I think with a bit more leadership and greater coordination, we could do more about that. And we could also utilise more the data that we get from what people use personal health budgets for, which would then feed back in a nice loop into our commissioning and what we actually might need to commission differently in the future. So I'm hoping the board will endorse taking that work forward through the executive group to look at how we might be able to expand that further over time.
Yeah.
Is there any evidence? How long have Dorset been doing that as default?
Ooh, I don't think so. A couple of years. Yeah.
So 2 years is supposed to be enough time.
Yep.
1 wouldn't be, but 2. On that basis, did they align their services to provide the necessary different ways of providing end-of-life care before they did personalised health budgets, or did personalised health budgets and the choices involved mean that there was a shift in services and it helped that shift?
I don't know the answer to that question, but evidence from where we've implemented personal health budgets in other places like continuing healthcare, for example, you can do them at the same time. And social care have got a huge experience of doing this. So yes, obviously there's a culture and behavioural change that's required in order to have a different conversation with that person, in order for them to understand what the range of opportunities there might be available to them and to make sure that there is access to those opportunities. I think you can do them at the same time because part of the personal health budget mechanism is giving people potentially the direct payment to be able to spend that themselves. And even if you just move from a mechanism where the statutory sector partner is commissioning that themselves to giving that money to the individual or their family to spend for themselves on the things that make sense to them, we know from evidence that just that switch means that family members and people themselves actually spend less money and they spend it more effectively and efficiently. So I don't think we have to wait to have everything perfectly set up before we make that move.
Thank you.
All right. Ali?
Thanks, Emma, for that update. That's really helpful. I really welcome it. And, you and I have had a number of conversations around personalisation. It's a big agenda item for us in the council. Just really keen for us to work together. I won't repeat what I've just said under the other presentation, but we've got a huge programme of work at the moment around personalisation. We're co-producing the way that we work and the solutions for residents with residents. Our steering group is co-chaired between me and a resident with lived experience. We're adopting a direct payment first model with our workforce. And we've got some really clear messaging going out around that at the moment. We're bringing in a personal budget calculator where Cornwall hasn't had this historically, or it had it historically and then it stopped having it, so that we can work really transparently with people around their individual budgets. And we're also looking at bringing in a more structured way of managed services to help people to manage a direct payment and make it much more accessible kind of option for people. We're also looking at individual service funds. So this is a directly commissioned service, but basically we commission a provider on behalf of the resident to manage the budget on their behalf and subcontract where appropriate and necessary. And just to be really, really clear and transparent with the board, we're really, really ambitious about what we're going to do around direct payments and personalisation in adult social care. So it'd be absolutely fantastic if we could do this together. Thanks.
Thank you. So I may be, so Martin, go for it.
Just totally supportive and of both sides of the equation here. I just wanted to make the point that there was, or still is, an outstanding audit action on some of the governance internal to the ICB around personalisation, personal payments that still needs to be slightly tightened up, and I think was wrapped up in to do with the restructure, I believe. So, hopefully as part of the restructure, we'll have those controls put in place, and as part of, I think we said in this paper, joined up processes, etc., which is all part of that.
I think it's a really important area of development, Emma, and I think it links absolutely to our overarching strategic intents. So I strongly support it. I'm not clear I understand the budgetary implications. So the only question for me is, as we increase the use of personalised health budgets, that I understand is NHS resources. So have we factored that in appropriately, and is that clearly within our plan for this year?
I completely understand. I was going to ask that very same question myself, because I'm trying. I get this if this was in social care, adult social care. I do get that. I'm trying to work out here where, when you say it's very clear that this is actually cost efficient and whatever. Well, actually, in order to see X in and half X out, or the other way around, there must be some model of that. So I'm really keen to actually hear the CFO actually go, if this is more than a pilot and it's scalable, it actually is a productivity gain for us, or if this is, with respect, something which is an addition to our core purpose, and if it's an additional cost. So I think we have to be really careful here that we understand the financial implications of scaling this. I'll come to you in a second.
Simon and I spoke about this yesterday. So if we turn off personal health budgets, it will be full again, because the people taking the discharge collaborative is using them to get people home and keeping them there. So we're having to make sure that that is definitely in place this year. Where I think this gets really exciting is once we're down at a me version of the population level around my personal health and anticipation. So if we go back to that diabetics example that I am really excited about, I don't know how much new metformin type tablets cost, but I suspect metformin's cheap as chips, but there will be things that are better. If we didn't prescribe those for people, what's the budget that's freed up from the non-prescribing of something that is just going to keep you at best on an even keel? There'll be lots of hospital admissions that we won't even have to cost into that. But if we help people to manage their own long-term condition, we would end up with people not having the burden of an amputation or vascular disease or renal dialysis. Now, for each one, we'll have to do a little mini business case that shows the benefit for each pathway. But I think the principle that's being described here is if you give people a budget that's about their own health and their family's health, they spend less than we would even think of. And it's not just around the discharge or the social care bit, it's around health too.
So Neil, go first, and I'm going to still pick up on Steve's point.
I can't remember the exact figure, but that figure's been postulated for Cornwall if you extrapolated the health creation model around diabetes and good eating instead of metformin. Was it 15 million over 5 years or something like that, just on metformin prescribing?
So we're doing some work with Arden Gem at the moment to build the business case for diabetes. Now, some of it would we couldn't release in year because we might see a benefit immediately around inpatient stays, but we've already got that factored into our sums for this year. Where we might see a difference is in prescribing costs. And yes, we've got pressure on our prescribing budget, but we would be able to yield some savings from the prescribing budget to pay for different services. And I've just been speaking to Rohit and Richard. So if we set that up as a longitudinal trial, for one trial that they're in at the moment, each patient included on an international arm is 20 grand. So we're starting to see income generation into our system around the things we need to do that could actually help us to have what else could we do around population and community health creation. So I don't think we can sign up to a figure today because there isn't one in the paper either. But the principle is, I think we should endorse.
So here's the direction of travel I want to just challenge. I mean, I am utterly committed to one-to-one personalisation. That kind of thing. Do not misunderstand me, all right, in any way, shape or form. But we've got to be clear. If you start building personal budgets, there's no more money in the total pot. So where is it over here that you'll start or will start reducing to be able to fund that? Because one of the things that was like, Ali, you're going to correct me because I'm probably wrong here, but the council's budget didn't get any bigger as a result of introducing personalised budgets. So what we have to be, right. So what we have to be careful of is we don't get consumed by the concept of it, only to find out that actually it becomes a cost to us as a total. It might be quality driven and it's all the right thing to do, but if you're not seeing a commensurate reduction over here, it's a net gain, and that's what we have to be careful of.
So I think it's important to just look into the detail of where personal health budgets are currently used. So the right to have personal budgets at the moment are currently in 3 key areas: Section 117 aftercare, continuing healthcare and wheelchairs. And that's as a result of NHS England doing quite a lot of research around, it being the right thing to do for those particular areas of work, but also the cost-saving issue. So right at the beginning of personalised care back in 2016-17, there was a lot of work done in Devon, actually, around the implementation of PHBs for CHC, and they found across the board 7% reduction in the budget for CHC, just as a direct result of people and families managing that money themselves, because people are really good at managing money. Sure. I was just chatting to one of Ali's colleagues actually on the call this morning, and we were doing a joint presentation on social care personal budgets and personal health budgets, and they were saying that they've got sums of money that they take back every year because people actually hold on to money. They're very thoughtful about how they utilise it. So there's a real, I think, the cost benefit needs to be thought about in terms of different programmes of care, I think, and the answer won't be the same across all of them, John. So I think where we're thinking about ongoing personal health budgets, you do really need to think about that cost benefit analysis. But the one-off personal health budgets are again another area where you can build in personal health budgets into contracts or programmes of work that aren't additional money, but where you're thinking about contracting out. So People in Mind, for example, which is a jointly funded service between the ICB and the Public Health. Within that contract, we've built in a personal health budget element, which enables us to give one-off personal health budgets to individuals that keeps them out of hospital, supports their mental well-being, enables them to engage in small amounts of goods and services that would keep them safe and well. So I think there's a mixed model. So I'll get back to Kate's point about saying there's not an answer or a single sum. It's about thinking about which areas we're looking at PHBs for.
Part of the evidence problem that I think we have is scale. We're small. So to make changes, the numbers aren't great, but we've got potential of a transformation programme. We've got a research and innovation department. And if Rachel was here, I know she'd say it because she said it many times at ICA committee. There is evidence out there. We just need to go and look for it and believe it because it's been done at scale in other places. So I'm just challenging that. I know this is difficult, how we make change at a time of flatlining budget-wise, but some of it is about going out there to find the evidence while we transform elsewhere, not just expecting ourselves to do it, because we're not going to do it quickly, because we're not going to have the numbers that people will believe.
Can I make a suggestion? Because there are some conditions or pathways that lend themselves beautifully to personal health budgets because of the issue around control and tailored care. So I think we should take this away, come up with the pathways that we'd be looking at. We already fund 3. One's discharge, one's the community development workers, and one's the third that you've just mentioned.
And Community Gateway.
And Community Gateway. They've all got personal health budgets built into the service model. Maybe Chris, Susan and I could go and have a look at the CRG work programme and then which pathways we will ask them to build personal health budgets into those pathways within the current quantum, so that we're not looking at it as an inflationary pressure, we're actually looking at it as a deflationary pressure through the evidence that we know is there for personal health budgets.
I'd be much happier if you'd all been Happy to enjoy it. You have, Steve, I think it's your
Really helpful.
question.
Yeah. Thank you.
It's a fab suggestion.
We should think about mental health in that as well, shouldn't we?
So I'm thinking of just prescribing for anxiety and depression, both of which tablets don't always make a great big difference, but other things could. So yeah, agree.
You be clear on the minute that would come from that. So thank you for that suggestion. Could I just add a broader concept, and feel free to shoot me down on this one. I'm just wondering whether the finance team with you might actually just ask the basic question about the direction of travel of personalised budgets beyond that, because there's something for me about learning from what councils have had to do across the country in terms of moving from what were expensive in-house budgets to personalised care. That was a massive strategic change for the whole country. I'm just wondering whether there's something here that you might want to think about. Well, how far does this go? Was that too soon?
So Ali's got her hand up.
Ali?
Yeah, I'm really happy to support. We're trying to get the infrastructure right and understand the kind of opportunities and things like that. I'm really happy to work across. I put it in the chat box as well because it would be silly for us both to have infrastructures that support the management and oversight and audit of budgets in this way as well. So it might be worth us having an opportunity to have a conversation about what we can do together and what we need to do separate. But how do we have a kind of single kind of interface and process so people can understand it better as well?
Start first, and then we're going to go Kate, and then as your paper, we'll end up with yourself. So thank you. So.
I think we need to be slightly careful about having some proportionality of approach here and about proof of impact. Because I think there needs to be a measured approach that both says, how do we prove the impact of what we're doing at the moment and how that's being asked to show its efficacy and outcome, and what a new thing is going to do. And I understand there's only one budget and we can only spend the same pound once, but I think we need to look at both things and then look at them in comparator rather than just saying to one side you prove your impact. Yeah. So I think it needs to be both ways.
Where would you like to?
So I think we should go away and do the work that I suggested, and that we're clear on a number of pathways that we would like to look at it. Yeah. Look at this through this year. I think there is something around us not having too much of a set expectation around what will make a difference, but that we describe the changes in a pathway we'd like to see, and then our clinicians and our community workers work with people to affect that change through personal health budgets, because giving permission is the greatest way that we're going to see the greatest benefit. So as long as we do it within a controlled financial space, then I'm really happy.
The thing I was going to ask, I guess, is if there are other geographical patches that have done it at scale, can you measure what that's done? So what they've invested in personal budgets or what categories of care have changed in terms of spend profile?
Disinvested in as well. Yeah.
So is there a mapping somewhere that we can use?
There's international evidence if we care to use it. So yeah, we can get that, but you know what we're like in the UK. We have to repilot it before we can say it's any good.
And the proportionality, I think that's a helpful challenge. But if we move from the current Cornwall position of just over 4,000, the current Dorset position, which is 16,000, and we've got a higher population than Dorset, we'd be moving to something like 24,000. I think the average spend from a mental health perspective, that's the only figure I've got, is about £3,500 per personalised health budget. So if that's the level of spend we're talking about across 20,000 additional personalised health budgets, you're talking over £50 million of expenditure. So I can see there's the opportunity, but it does feel like the approach Kate was setting out to give us some assessment about what is our ambition would be really helpful. And that might be where we land, and that's then a significant multi-year transformation programme to achieve that. So I think there's a real opportunity here, but just understanding the scale of the intent, I think, could be really helpful.
Capture. Do you want to just play back what you think the minute was then, from Kate? Or Kate, you play back the minute? Because it's not the recommendation that's in the paper.
The next steps, though, isn't it?
Well, can we be really clear on what we're going to commit here? Because we're not saying we're endorsing the work to take forward, or if we are, we're saying we're endorsing it, take it forward for a specific group of areas.
So yeah, can we make the next? So the recommendation is that we endorse the work that's been done to date on personal health budgets and the rollout through the county, because it's what we're seeing is working. That we're committed to providing the flexibility that personal health budgets can sometimes give, but we need to do it in a managed way. So we'll bring back to the June or July board a proposal of which pathways we would seek to look at the impact personal budgets could make, but within the quantum of spend on that pathway. So we're going to have to do the work to say what the programme spend for that pathway is before we can step into it.
Happy with that?
Yeah, very much.
Could we also add in the joint working? Because I think there's an element about looking at different pathways, but also there's something about how we could look to have much more efficient and joined up processes and administration opportunities between the local authority, because the process, the processes are virtually identical as other budgets.
Okay, thank you. So we're into, that's that paper finished, unless anybody else wants to raise anything. Can I move on? Yeah, lovely. Thank you so much. Very good. Forward agenda. So I would normally say, look, you've had a contribution, Chief Executive, take it away. But I want to use this opportunity just to ask you, this is the time, and over the next 3 or 4 months, where we have, knowing now that we're not going to have an August board meeting, right? So it's June, July, and then suddenly it feels like it's autumn before we even start. And then guess what? We're starting September in budgeting, and then it's all gone again. All right. How we might use the next couple of months to focus on some of the things that normally get squeezed out. And I'm thinking things like climate work, Kate. I'm thinking things like the state strategy. I'm thinking things like maybe a bit more quality time on digital. And that, I don't mind what they are, but these things tend to get squeezed out from our discussions. And in order to use the next time and the time after, I would just like some sense as to what you feel as a group really ought to be on the next 2 board agendas.
Equity of outcome, and what we mean by that, and how we're going to set ourselves some metrics around that. And I know that's going to come through next.
Then what does that mean?
So, what is our equalities, diversity, inclusion strategy? And I know that some of that will come through the Personal Experience and Equity Committee, but I think we need to be much more developed in terms of our strategy around which different groups of people are having different outcomes of services, a little bit like we've just seen with the presentation today.
I thought the intersectionality
was great.
Was great, because you could just see how the layering would happen. That, I mean, your life isn't as great as it could be. I suppose my point is, the reason why I stepped outside was the feedback from both of them is 40 minutes to do a presentation, to have a discussion about research is like nothing. So if we're going to do some of this stuff properly, I think it's in our development days, we need to be tossing the strategy around for the plan to come back to the board.
Yeah.
So I don't know how many development days we're going to have between June, July, August and September, because I think we could defer some of them to development days with a plan coming back to the next board.
So we always planned, and we always started. I don't know why they've not been put in. We always had them every 3 months.
Mm-hmm.
So if it's all right with everyone, we'll get them back in the diary. Is it you okay? Do you want to intervene?
Carry on.
Yeah. Are you okay if we go for getting back in the diary every 3 months?
Mm-hmm.
Yeah, is that all right? We'll take a day
And
on.
then if SEG comes up with a suggestion as the focus for the development,
Yeah.
and then we can get wider teams in to set the strategy for us to debate it and effectively to sign it off.
Yeah. So to be fair, I wish Debbie was here, because when I first saw the slide deck, I have to be honest with you, my heart sank. There's no way you're going to get 40 slides done and a Q&A session in 40 minutes. So,
did.
Well, I still think there was not enough time for a Q&A, if I'm honest with you. So for me, if we're going to do a deep dive, I'd rather know in advance, we give it an hour kind of thing, or it's taken offline and it's done differently. But I think we've just got to get collectively better on managing expectations as to it's paper read, we'll have the debate, or it's present and debate. And if so, is it in this meeting or is it in an off thing? Because I didn't feel like I actually did that justice. There are loads of questions on AI I wanted to ask and digital stuff. But I chose not to because we were running out of time. So if you have a little think about almost the next year and introduce the concept of quarterly away days for the whole group of us, then think about, if we are going to do a deep dive, what can be a 40-minute session with a pack read and then almost a Q&A. So we've got, for example, in here a children's and young people mental health deep dive in June. Now, Debbie's not here to answer whether she wants to do that or not, but I would resist doing it for another 40 minutes if it was going to be like that again. Only on the basis I don't think we did it justice.
I suppose it also depends on the balance of what we've got in part 2, doesn't it? And whether part 2 takes up so much time, or we dedicate a couple of hours to a deep dive at a board meeting when the part 2 is quite small, because we should be doing most of our business in part 1. So again, if we could take it away and maybe map through, if we do some mapping in my small exec and then take it through the system executive, because there is something around place-based strategy too, so we could become very consumed with our big Cornwall-wide strategies, when what we might be asking for is that's the strategy, what's the West response to it, what's Mid and Central's response to it?
Sorry, it's really just on this subject of time and how we do things. In June, as you just said, we had children mental health deep dive. You've also got there, and it's been coming for a while, transforming primary care, and it's transforming primary care in the Fuller report. I think given what we've been talking about in terms of system resilience, that needs some time on that board discussion. And I'd rather not see it put off, because I think the work's being done to present it in June, but I do think that it shouldn't be shoehorned into 20 minutes. It needs time for questions and answers and people to challenge and ask questions, because I think there's going to be a lot in it.
I'll ask for a bit of indulgence in a second for the next 2 meetings, and you'll see why in a second. But Kevin, you wanted to ask?
Yes, build on Kate's points really around if we planned development days around something like place, I think what would really work, because we were seeing it work in our exec meeting, was working with Chris, Susan and colleagues who are driving the initiatives from a outcomes and what it means for people point of view. I can then provide and this is how digital is enabling it, rather than me trying to do digital in isolation from those initiatives. But I think probably what I do need to bring to board, or certainly through a committee, is something similar to what I do in the providers, where I provide a quarterly update on the key programmes, which is much more about measuring the progress and delivery of a big portfolio of work. Because I think the two things are a little bit different, if that's helpful.
I've got a suggestion that I need your support on, and I'll look to my chief executive and company secretary for advice on it, because it might not land well. Recognising we have statutory duties, if you look at how much of our day is taken up by committee updates, DD updates, this, that, and the other kind of thing, it does leave some of the chunky items compacted. And I'm just wondering whether, in fact, with your support, we could actually only have the papers as normal, but next time and the time after, go through a process of, unless somebody wants to say anything, I'm just going to take them as read, and we'll spend time on the primary care for that report. We'll spend time on the children's, if these are the ones we're going to do. And we actually say for the next two months, we'll have to do the things we've got to do, but we'll do them
Exception reporting.
Punchy, and we'll give quality time. Now, if you're up for that, I just need your support on that, because it's not, I don't want you to feel next time I'm not paying attention to it, because you'll say, well, am I writing the papers? But
so as long as the work's done in the committees, because that's what our committees should be for, then a report comes to the board, and if there's nothing to do other than say to the committee, God, you're doing a great job, it's an exception report.
So I want to just call them out then, all right? Are you happy for us to have the Transforming Primary Care and Fuller report come to June?
Yeah.
Yeah? Great, because we'll give you that quality time. The innovation update and digital strategy from, I guess, you and John Sindel.
So can we defer that to July? Because then it gives time for it to align with the programme of care.
That's fine. All right.
Might be on leave in July.
You want to do it in June now?
Well, Tracy says yes, do it in June, but
I'm just saying we've deferred it previously 2 or 3 times, but the timing is important, isn't it?
Happens off, we can't do it. So
let's do June on that one then. PSIRF gap analysis.
PSIRF gap analysis, does that need to come to the board in June? Is that not a QPOC?
It is QPOC, and I think that might be something that could go to SEEK as well, potentially.
Yeah.
You find an alternative route
for
that one. Thank you very much. Are we up for a children's and young people mental health deep dive?
If we are, we need to spend time on it.
Yeah, that's why I'm going to.
So, Chair, we've got a paper that's going to the One Vision board around particularly the waiting lists for children and young people. I think it's insightful, but I would like it to go through the One Vision board because that's
All right, so that will be July then.
so we can take
Yeah,
yeah,
so that's
that would
July.
be helpful.
Okay, because the other thing I should have said when I said I was going to be much bit more punchier in part one next time. Okay, if it is possible, we'll have the smallest amount of time for part two in the next 2 months as well.
Yeah.
And that will allow more quality time as well. So, will you be ready with a dentistry update? Given all the changes at government level and in-out, shake it all about with. Well, that can come in June, dentistry?
When's the piece? No, I think it's coming to PCCC in June. I'm not
What about
sure in terms
July?
of the timing, whether it'll be July.
Can we come with a cost of delivery plan in July?
Okay, so that's July. Can I ask about
July.
the estates update then?
So we could bring estates to June, couldn't we? Do you mean estates or capital?
Whatever you want it to be. I guess I'm just asking the question. We haven't had a quality debate on it.
So I think it should be capital linked to estates, so including primary care. That's a big piece of work for Matt.
Happy with that? Yeah.
That's absence, yes.
Thank you very much. And the only other one which you...
Just to check, that's a really important bit of work, but John, were you suggesting that that comes in June? And is that sufficient time for that scale of work that you've just described, Kate?
The Stuart's just put in the chat, so general practice have put in their practice needs, and I think we've responded to some of it, but not to others. We'll know whether we've got the capital money or not for this year, and we'll need to sign off what we're going to do with it. And I think there is just something around our capital plans for this year. Once we're out of June, we're in the second quarter, so I think it would be good if we could see it all together. Is that possible, Simon?
Aspire to do that. And just capturing the point for the minutes, Molly, can you make sure that both innovation and digital are on June?
Might be a month too quick, to be honest.
Then we're deferring everything to July. That's
Yeah,
the
no,
problem.
just we can look at a capital plan because we've got one already, but we won't have much information about what started and any detail that runs against it.
Well, we'll have schemes in process, of which there are loads, and we'll also have the general practice gap analysis that is with Kirsty.
We'll start there, and if
We
we
can
need
do that. We do an update on capital spend, and that's fine.
Molly, just read back. What do you think we've got for June and July then?
I've just noted the ones that have been deferred.
Okay, so I've got for June innovation, digital, because they're two separate things. Innovation, digital, an early bit of work on estates,
No, there's no
and transforming primary care. Those are the ones that I've got as, because these are huge bits of work in their
They
own
are
right.
huge bits of work.
And I wanted to give you as much time for the executive team to go, God, I've got to prepare for that.
The
So-
transforming primary care is already being managed through PCCC, isn't it? It's the board that needs to be cited on the size and scale of the plans and the risks that sit within it. So that is very manageable for June. Andrew will be able to bring an innovation update, but it will be an update from the AHSN. I'd like to add on to the end of that is the approach to research and how the clinical reference groups will pull it all together. And Steve, I don't know who your director or head of research is at the moment, but they need pulling into that discussion.
Yeah, very happy to, and Chris is already connected, but we can make sure we've got that lined up. Yeah.
And also from the Plymouth end, so that we've got maximum opportunity for Cornish resident inclusion on trials.
And you're going to do one on digital.
Digital.
Yeah, just one personal request on it. Can it actually be outward facing in, not our facing out? I'm not, you know what I'm trying to say.
And they're asking for 50 million.
Okay. Has that been a helpful discussion? Have we missed anything on?
Apologies, we have.
Yeah.
It's only because I propose it in the meeting.
Yeah.
It's the risk paper for June.
Oh, yeah. Bring this paper back in June again. So the deal is, bring back your papers as usual, but we're going to be more taken as read, deal with it. We're going to truncate as much time on part two, put as much into part one as possible, and have quality discussion, so less is more on these items.
I think we've got to bring back a finalised joint forward plan as well.
I think
following the operating plan being, there's a view and some feedback we've had, there's a request for us to just review and finalise, so that will need to come back here. It should be relatively straightforward because it's already been signed off once.
We just need to fill the gap. So each statutory organisation said they'd like to see it with sufficient time to comment before it comes back to the board.
Okay.
So we need to get that.
Could you help
working
us on that journey
progress.
then? And if it works, fine. If it doesn't, it'll be July. Does that work for you?
Yeah, but we'll need to submit it at the end of June, so we'll just need to work out how we manage that. We can do that offline.
It's offline.
Yeah.
Helpful discussion? Lovely, thank you. So let's go back to where we're at. Gosh, all these papers. We had no questions. So I don't know quite, do have anybody from the public out there? If we do, are there any questions on the agenda you would like to ask? I'll just pause for a few seconds.
I don't think we've got any members of the public
No,
still
in
there.
which case, Molly, I'm going to call a close to part one now. So we're 15 minutes over. No, but I knew that part two, we've got plenty. We're going to suck it back up again, all right? You see, this is how it's going to work, everyone. You see the trend. Peter, if you can switch it off now, I'd be very grateful. Thank you very much.
Thank you. See you later.
Thank you very much, everyone.
Bye.